joining us tonight.
Yeah,
All the best. Thank you.
Hi, Abida. Hi, Abi.
So Abi is her nickname?
Yeah.
Abi. Abi.
Abi.
Abi.
A great welcome, Professor Kat. It's our great
Hi, good
honor
evening.
to join us.
Hi.
And,
Thank you so much. Thank you for
we
invitation.
We are greatly appreciating all your efforts through all the field of the neurosurgery in Japan, in the world, in the neurovascular, and especially in the women neurosurgeons, and in a lot of fields. You are a symbol of the great enthusiasm in the world now.
Oh, thank you. Thanks so much. So that's too much word for me. Thank you.
Professor Kato, he is Omar Youssef,
Hi.
colleague. He's professor of neurosurgery at Ain Shams University in Cairo, and he is chairperson
Yes.
in this session.
Welcome.
Yeah, thank you so much.
Thank you.
It's time to start IT. Ahmed. احمد ثانيه واحده بس هستأذن منهم. اطلع stop share please. Professor Kato, just excuse me 2 minutes to introduce all
Yes,
attendees.
of course.
We are going to put this music for 2 minutes exactly, and then we will start the session.
Please.
Thank you very much.
Thank you.
Ladies and gentlemen, it gives me great pleasure to welcome all of you in webinar number 32 among the series of webinars organized by the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies. As second vice president of the World Federation of Neurosurgical Societies, I understand that one of the most important missions of our organization is to promote educational activities among all young neurosurgeons, especially in the developing countries. Today's webinar is a special webinar because it is the inauguration of the Egyptian Women in Neurosurgery. And it's also a special event because it represents African-Asian collaboration. It's collaboration between the Continental Association of African Neurosurgical Societies and the Asian Congress of Neurological Surgeons. I would like to express my sincere appreciation for Professor Yukukatu for giving us such opportunity and for supporting the inauguration of the Egyptian Women in Neurosurgery. I would like also to express my thankfulness to all our speakers from Asia. Dr. Sharon Theophilus, she's from Malaysia. She's the chairperson of the Women in Neurosurgery section, ACNS. Abida Shah, she's from India, and she is the education chairperson of the Women in Neurosurgery, ACNS. Professor Kostadin, he is affiliated to the Department of Neurosurgery at Jiki University, Tokyo, Japan. I would like also to thank our distinguished speakers from Egypt and Africa. Dr. Nihal Shaaban, she's consultant neurosurgery from Tanta University from Egypt. Zarina Shabhi, she is from Tanzania, from Dar es Salaam Hospital, and she is the first graduate of Africa 100 project of Professor Majid Sami. Dr. Mariam Ghanim, she's affiliated to Azhar University in Cairo, Egypt, and Dr. Heba Azzouz, she is working in the Department of Neurosurgery, Faculty of Medicine and Cairo University. Chairpersons of this webinar will be Professor Yukukatu and Professor Omar Youssef, Professor of Neurosurgery at Ain Shams University, Cairo, Egypt, and myself. Thanks to all of you for contributing to this neurosurgical activity and for giving much of your time and sharing your experience and knowledge with everybody. When you look at this table, we can see that women in neurosurgery in Egypt right now, they are only 21, and they are working in different centers: Azhar University, Cairo University, Banha Ministry of Health, Tanta University, Mansoura, total. And this shows the incidence among the different centers. An important question I'm always asked in many events: why Egyptian women in neurosurgery are few in number? However, when we look at other specialties, we can find that women in Egypt in medicine, there are many. Our Ministry of Health is woman, Dr. Hala Zaid. Also, this photo shows a memorandum of understanding between the African Continental Association of Neurosurgery and the Faculty of Medicine at Cairo University, and the Dean of the Faculty of Medicine at Cairo University and Vice Dean, both of them are women. When we have a look at the neurosurgical certification in Egypt, we have two types of certification: the degree of doctor, which is awarded by the Egyptian universities through a training program, which extends from 7 to 8 years. And the another type of certification is the fellowship of neurosurgery. It's awarded by Ministry of Health through a training program, which extends from 7 to 9 years. I go back to this important quotation, which is taken from a publication of one of the Egyptian leaders of neurosurgery, Professor Said El-Ghandour in neurosurgery, saying becoming a neurosurgeon in Egypt is a long, arduous process. I also happy and glad to show this publication of Peter Black in the World Neurosurgery 2010, which is evaluating the training programs in neurosurgery all over the world and evaluating the process of certification. The evaluation is out of 40 points. And as we can see that Malaysia is taking the highest score. And I think Sharon should be very glad about this information, that it is the highest score, 21 from 40, whereas Egypt is taking 80 out of 40. When we look at UK, it's taking only 19 from 40. And so our training program in Egypt is very long and is taking a very good score according to Peter Black publication. Africa is grateful to Professor Yukukatu. For years, Professor Yukukatu has been working hard in order to promote neurosurgery in Asia and globally. She's also supporting neurosurgery all over the African continent through the outstanding educational activities she's organizing and through donations from her own money to sub-Saharan Africa. And today, Professor Yukukatu is supporting the inauguration of Egyptian women in neurosurgery as Honorary Secretary of the Continental Association of African Neurosurgical Society and as President of the Egyptian Society of Neurological Surgeons and on behalf of all African and Egyptian neurosurgeons, I would like to tell her thank you with all respect and appreciation. Now I am honored to announce foundation of the Egyptian chapter of women. Let me first announce about this is the certificates. All attendees can print this certificate after the webinar. Just give us few days, like 1 week, in order to register all your emails in our system. This is the link you have to open. Username is going to be the email by which you register to this webinar, and the password is ESNS@1967. Now I am honored to announce foundation of the Egyptian chapter of women neurosurgery. Before starting the scientific sessions, I'm pleased to introduce Dr. Rabab Yahya. She is consultant neurosurgeon at Azhar University Hospitals, and she is chairperson of the Egyptian women in neurosurgery. She's going to give a brief introduction about the Egyptian women in neurosurgery. Thank you. Rabab, are you ready? Can you share your screen, please?
Yeah, doctor, I'm here. Okay, doctor. Can I start?
Please. Yes, please.
Okay. Good morning, good afternoon, and good evening, ladies and gentlemen. It depends on where you are across the world. My respectable professors, my colleagues, and dear guests. It is a great honor for me to take a part in this gathering that advocates the neurosurgeon females, the first of its kind in Egypt. To Professor Dr. Nasser El-Ghandour and Professor Dr. Omar Hamad, we owe them thankfulness and appreciation for their sincere effort in putting the cornerstone of the conference that will shed light on the role of female doctors in the field of neurosurgery. This is an encouraging move for all of us to take the same path of our role model doctors who spared no effort to teach us the sophisticated details of such unique branch of surgery. It's a pleasure to have Professor Yukukatu with us today. Professor Yukukatu has been actively involved in inspiring and encouraging female physicians to pursue the field of neurosurgery. She founded the Women's Neurosurgical Association of Japan as early as 1990 and went on to establish the Asian Women's Neurosurgical Association in 1996. These associations have played a great role in promoting the face of women in neurosurgery in all corners of the globe by providing fellowships, opportunities, and recognition. She has built a directory of women neurosurgeons in all countries, making the field a truly global community. She has established the women chapters in many neurosurgical societies, thus advancing the stature of women in neurosurgery. All the females here should have been passed through the difficulty of choosing this branch that is famous to be masculine dominant field. However, for me, I can say I was attracted to defy my fears that dominated my successful graduate and dreamed to be a responsible neurosurgeon. I am proud to be among the first line of female doctors in the field across my country, and I took my first surgery in 2011, and it was traumatic brain injury. The great moment for me when the patient opens his eye and his limbs are moving. Then I went through a very successful spine surgery, but still skull-based surgery, especially the endoscopic one, is my favorite. My message to the fresh graduates: don't be afraid of being a neurosurgeon. Do your best in learning more and more from your treasured professors. Love and respect your patients. Read and learn more every day, and you will harvest success by time. Again, thank you so much, Dr. Nasser El-Ghandour and Dr. Omar Hamad, Dr. Yukukatu, for giving me the opportunity to represent the neurosurgeon females and I will always try to do my best to continue my professor's sacred mission. Thank you for attention.
Thank you very much, Rabab. Now I am honored to introduce our great Professor Yukukatu for a welcome note.
So thank you very much for a wonderful the occasion for all Asian female neurosurgeons, especially representative of the Asian Congress. We are very, very honored to receive your wonderful invitation. So as for the Asian doctors, it's the Africa is very far from Asian countries. So and also the very rare to see the the African doctors, of course, the lady neurosurgeons. So for us Asian doctors, especially a female neurosurgeon, and we are very, very honored to see all of you. And also, I thank you very much, Professor Nazil, the president of the Egyptian Society and the vice president of the World Federation, and also the vice president of the CANS. And also tonight's Memorial Chair is Professor Omar, and thank you so much for kind invitation this time. So we hope that we can have the good communication with all of you, especially the culture and history. The many things is different from Asia. We are very much looking forward to hear your the experience and also the knowledge during our 2-hour sessions. I really appreciate your invitation. Thank you so much.
Thank you very much, Professor Kato, for this kind introduction. And now we proceed to the scientific sessions. May I ask my colleague Omar Youssef to start to introduce our first speaker.
Thank you, Dr. Nasser, for your effort to establish this this chapter in Egypt. And thanks a lot and a great appreciation to Professor Yukukatu for her strong enthusiasm all over the world and all over the fields of the neurosurgery in Japan, in Asia, in neurovascular, and especially supporting the women neurosurgeons all over the world. Thanks for all our distinguished speakers, and thanks for all the attendees. Now, I welcome to call the Dr. Sharon to speak on the journey and the challenges as a woman neurosurgeon. Very nice topic. Please welcome.
Thank you very much, Dr. Omar. Good day to everyone, because we are all on different time zones. I first like to thank Professor Nasser for inviting ACNS WINS to this auspicious opening of your inauguration of your Egyptian WIN chapter. It is truly an honor for being able to include ACNS WINS in this inauguration. So I will go ahead and share my slide. So when Prof. Nasser asked me to present, I thought since this is an inauguration, I would present on my journey and challenges as a woman neurosurgeon, not only as myself, but also in general. So I started off how it began. When I was in medical school, it is kind of fascinating. I found neurology an interesting subject. In medical school back then, they hardly exposed you to neurosurgery. So basically it was neurology, but somehow or other I found the brain, the spine, the nerves very interesting. I mean, a lot of people find the heart interesting, but I found the brain interesting. It is like, for me, it's like the motherboard in a computer. The heart is the electricity, but the motherboard is still important. So then I became a medical officer in the emergency department, where I was exposed to a lot of traumatic brain injury. And as an intern, I had the opportunity of going into the operating theater to actually witness a craniotomy. And to me, I think that was the moment where I knew what I wanted to do. So I don't have an interesting story where I wanted to be a neurosurgeon since I was a kid. No, it's something that grew on me. And I think if you tell me, that's when my love story began with neurosurgery. So basically I fell in love with neurosurgery, and that's when it began. So I joined the department, and then this is the first person that actually welcomed me to neurosurgery. He is the head of department of my department previously. He's now retired. He was also the head of neurological services in Malaysia. Mr. Johari or Dr. Johari Sirega was the one who welcomed me to the department. And then, of course, there was Dr. Safari. So both of them sort of gave me a lot of motivation and inspired me to go on to take up neurosurgery as a profession. So I loved the work, and I never really thought about, what was expected, because, once you get into neurosurgery, you're in it, and it fills you up, and you become passionate about it. And that's what happens. And then through my journey as a neurosurgeon, I had a lot of mentors. Dr. Ramesh actually introduced me to vascular neurosurgery, which is one of my passion too. And he made it so interesting that, I took it up as a passion. And Dr. Azman is my other mentor who actually guided me throughout my training. Dr. Azmi Alias, who I spent a few months with when I was in Kuala Lumpur, and Dr. Ng Chokman. He basically gave me a lot of basics on how to be a good neurosurgeon, how to keep my work neat, clean. So I thank a lot of them. And you can see all my mentors were all men. So basically, when I joined neurosurgery, it never struck me about, okay, this is a fraternity, or this is a specialty where there are not many women. I do not know why I didn't think of it. In fact, when I was an intern, I was scouted by the urologists. They wanted me to do urology, and they said, you could become the first female urologist, but I wasn't interested in urology then. And so when I took up neurosurgery, it never struck me that, I was the only female in that fraternity. And when I joined the residency program, it was all men. It was all men, and I never knew there was any woman until I had the opportunity to meet Professor Yukukatu in 2006. And that was the first time I actually got a glimpse of a woman neurosurgeon. And I think I count myself lucky, because the first woman neurosurgeon I met was Prof. Kato, and she made me feel that even though you become a neurosurgeon, you can always remain elegant, and you can always remain sophisticated and feminine. So that is something I will always be grateful to. And then when I joined the residency program, this was my professor, Professor Jeffrey. He was the head of the program, and he was a tough man. So I remember my interview with him. All the others get an interview where they ask you questions. Other than the questions that were asked to me, he was also asked me, you're married. Will this disturb your work? Will it affect your work? And I said, no, I don't think so. I've been working in neurosurgery before this, and I have no issues. And I'm proud to say, when I joined up in the residency program, after 6 months, he actually told my head of department that he didn't expect, but he changed his mind about how women neurosurgeons were supposed to be. So I'm glad I did that. And when I passed out, he gave me this book. So the only two things I knew about neurosurgery from women's point of view was one, meeting Prof. Kato, and the other, reading this book. And then I suddenly realized, oh, it's a novelty to be a female neurosurgeon. Before this, I didn't realize it was a novelty to be a female neurosurgeon. And then over my time, I've had a lot of male colleagues that have helped me out. So I've worked with Dr. Liu, and this is Dr. Ashraf. They were one of the few doctors working in my hospital. We had only about four or five doctors, medical officers, and I was the only resident. So that meant I had to go into all the elective surgeries, and on top of that, I had to be on call. And basically, I did not have a life. And a lot of us will think that, I had friends who tell me, Sharon, you don't have a life. But honestly speaking, at that time when I was going through the process, it didn't feel like I didn't have a life, because I was enjoying what I did. And so I graduated as a neurosurgeon from the program, the local program, is what Professor Nasib mentioned just now. I first worked in Hospital Kuala Lumpur with Mr. Safari for about 2 years to get my experience. And then I moved back to my present hospital in Johor Bahru, which is actually the southernmost tip of Malaysia, just next to Singapore. So what challenges do we did I face when I joined neurosurgery? So basically, I didn't have much challenges or what would I say, problems when I was going through the program, because I made sure I was dedicated and I gave in my time. So personal problems that you have is usually when you're challenged is if you have family, if you have children, yes, you have to divide your time. But I believe all this is to do with prioritizing and how you prioritize. When I became a neurosurgeon and I graduated, of course, there was a lot of ambitions. I wanted to do a lot of fellowships, go here, go there. But unfortunately, my dad developed Parkinson's. So the moment I graduated, a few months later, he was diagnosed with Parkinson's. And there's just me and my sister in the family, and she lives in another country. She lives in Australia. So basically, I was left to tend for my parents. My mother was been diagnosed with rheumatoid arthritis for a long time. So she couldn't really take care of my dad. So I took care of her. And it's been a journey, but somehow or other, I've managed to go through it and still balance my work. So it was never an issue. And also I'm married, and my husband has never complained. He's an orthopedic surgeon, so he understands my job and he fully supports me. So I think that is one of the things that keeps me motivated. So what challenges do we get in the work environment? Career and training progression. This is what a lot of trainees and young women neurosurgeons always complain. There's a lot of rigid and unsupportive policies which do not actually support women neurosurgeons when it comes to them having a family or balancing their life. And mentors. Sometimes it's very difficult for them to even get people or mentors they are willing to mentor them. Okay, respect and value in the surgical team. This is sometimes difficult. Sometimes there's a sexist and hostile working environments. Okay. Job satisfaction. This is another thing that because they cannot balance their work, they sometimes find it difficult to get job satisfaction. It's difficult for women to get leadership positions because of the multiple problems above. And of course, career opportunities sometimes is difficult. And of course, sometimes we talk about referrals from other doctors. Sometimes when you're a woman, they tend not to refer to you because they don't think you are you are good to be a woman neurosurgeon. So the challenges in the work environment, career and training progression. Of course, I am lucky. I was capable of going for some training. I went for skull-based workshops. I've had an opportunity to meet people who have actually able to motivate me, right? So he gives you support and he tells you that, you can do this. And challenges in work environment. So you can see here in this group, basically this is my residency program, all males except me, I'm the only female. But I never felt left out. I'm somehow grateful that my fellow colleagues always kept me in the loop, always made me feel included, always respected me. And when I graduated and I became a neurosurgeon, I was also included into the fraternity, and I was part of the team whenever they have any important meetings or examinations. I was always part of the team. And this is my department now. Again, I'm a consultant there next to my department boss, then that's me. And these are all the trainees under us where we train them, and they are my residents. So I've not really got the opportunity to feel that the working environment can be hostile. I've had very pleasant working environments. I think the people we work with know their limitations and what they're supposed to, how they're supposed to behave like. So job satisfaction, I think job satisfaction is up to you. All right. I believe for me, my job satisfaction, I've had great job satisfaction. I not just only operate. I believe when you do your surgery, you actually, if you're passionate, you do not think about anything else. So I do training. So here you can see even I give my surgeons the opportunity to train, and I supervise them. So this is something I think it's special. When you're a woman, you do develop patience. So patience helps a lot, and that helps you to become a good teacher. You also have a lot of job satisfaction in teaching and training your juniors. So of course, I do a lot of other work. And if you can see here, this operative theater here is a special intraoperative CT operating theater, which I was lucky enough to be given the job to actually oversee the building and completion of this operating theater. So for a woman neurosurgeon in Malaysia, it was actually a very honorable task given to. And if you come and visit my hospital, I will take you for a tour of our operating suite, so you can see how much of work and effort has been put to it. It is special. So this is one of the things that was given to me by my boss. And the other job satisfaction is I do a lot of training, teaching medical students, motivating medical students. And every day there are different women doctors or young students who come up to me and say, hi, Dr. Sharon, what do you think? Can I be a neurosurgeon? Or can I be, or what does it take to be a neurosurgeon? So this is something that motivates me to keep on doing and giving everyone a good impression. Access to leadership positions. I've been given the honor to actually join ACNS WINS, and this has given me some access to some leadership to be able to motivate women into neurosurgery, and also to make this neurosurgery fraternity an inclusive fraternity where women can come in and showcase their good works, their expertise, and what they do. Career opportunities. There have been a lot of career opportunities. Like I said, I've been given the opportunity to travel, to learn. Here, even a microvascular anastomosis course in Taiwan. And of course, I've been given opportunity to even run workshops. So here, this workshop was in WFNS Symposia in Malaysia. I ran a 2-day workshop, 1-day microanastomosis with RAD, and then the second day endovascular workshop. So it was a really great experience for me because I got to meet a lot of top people. I got to meet Prof. Binsu, and it was a great opportunity. And I also train medical companies, their staff. I also train a lot of nurses. I am part of the advanced diploma training for nurses in Malaysia. So these are part of the many opportunities we get. And other than work related, I do other things. So when you talk about referrals from other doctors, do they not respect women neurosurgeons? I think that's the wrong impression. They do. It's just that how you make yourself out there. So I've given talks for ADHD, autistic kids. I've done meets up with other doctors from other fraternities, such as surgeons, cardiothoracic surgeons. So you keep in touch, and I keep the social communication going. So ACNS WINS chapter was particularly created to educate, inspire, and encourage women in neurosurgery. And this was set up by Prof. Yukukatu in 2018. And our main aim is to identify obstacles that are gone through by women neurosurgeons, training and development, mentor and foster growth of female neurosurgeons, eliminate discrimination, and of course, encourage them to write an international paper presentation and also give awards. The last award we gave was in 2019 in the Beijing WFNS, where we gave an award of $1,000 USD for the best abstract from a woman neurosurgeon. And as a woman neurosurgeon, you need to build friendships. You need to build friendships with other women neurosurgeons and your male colleagues, and also build a group of friends outside your work, to have diversity, to even know what the common person wants. And here is the female neurosurgeons in Malaysia. You can see there's quite a big number of us. There's about 20 of us at present. We make up about 15% of the total female neurosurgeons in Malaysia. And when you say you become a neurosurgeon, you do not have to give up your life. I do horseback riding. I still play sports. I play badminton with my fellow colleagues. Here you can see we still go out. And here you see we are having the favorite fruit of Malaysia. It's called the durian. It's the king of fruits. I'm not sure if you have tried it, but if you come down to Malaysia, I'll take you out for that. Thank you very much.
Thank you very much, Sharon. It's very interesting presentation. I was following everything in your presentation. It's very interesting. It's a very good example for all our women neurosurgeons in Egypt to know that nothing is easy, and neurosurgical career is difficult, and it's long way, it's long journey. Really, we hope one day we can meet you in Kuala Lumpur and see your center. And I'm very, very glad that you gave this presentation in this webinar. Now we are going to invite the great Professor Yukukatu. She's going to be our next speaker, and she's going to speak about how to enhance collaboration across the borders, especially among the young neurosurgeons generation.
Thank you so much. Thank you. I prepare. And thank you so much for a kind introduction. Dr. Nassel is very kind, very warm heart. I know him for many years. I thank you so much. And today, just I was very impressed by Dr. Sharon's nice talk. So I encourage her and her team. Sorry. So this is just I repeated my slides. So the interaction, the wins goal, the scientific thinking, and promote research. The research work is very important, and also the social issues. And also finally, the gender equality is very, very important. And this is a video when Morocco. So we had a very nice hands-on workshop, both endovascular and also the open surgery. El-Ghandour is the introduction for all of us. And the one is a bypass hands-on. And the other one is endovascular, the hands-on. The first day we did some kind of the demonstration by panel, and also the second day we showed the live surgery. So we taught the young doctors how to do the bypass with the 20 small bypass. And this is the live surgery of the endovascular, which was, we did 2 cases. And on the next room, we did the live surgery for treating of the giant aneurysm with the suction decompletion, some techniques. So So such kind of the hands-on workshop, the face-to-face is very, very important for young doctors. So it's a time for the COVID. So how we can teach during this time. So the virtual and also the kind of the setting up the simulation laboratories to allow trainees to systematically acquire knowledge. So this type of the web seminar is very, very important during this time, and the young generation is very satisfied with that. And this is a non-technical skill online information such as neuroanatomy, radiology, and also the operative approaches, and neurosurgical atlas and the Roton collection, and the respective journals of the neurosurgical organization. And virtual reality is another very important thing. In cranial surgery and spinal surgery and in neurovascular surgery, all these fields, such kind of the virtual reality is not the live surgery. We cannot show them, but very, very similar to the live surgery, I think. And also the bypass, embolectomy or intracranial stenting and image guidance, and the robotic neurosurgery is another very easy to show them. So how we can educate during this time is some restriction of the travel. Maybe at the end of this year or next year, we hope we can meet in person. I think after the vaccinated people can gather in person in closed space where the in-person meetings will take place. Hopefully we want to visit Africa and Cairo, of course. And also the artificial intelligence in neurosurgery is a very important thing. It's generated machine learning and algorithm to improve our capabilities for diagnosis, prognosis, and patient management. So this AI is coming up soon, and also the formal predictive analytic use available data and the statistical algorithm and the machine learning techniques to identify the likelihood of the future outcomes. So key neurosurgical application of AI is a robot-assisted surgery, automated preoperative planning, and the diagnostic brain imaging classification, and the surgical candidate selection, and the prediction of the postoperative patient outcomes, the localization of the epileptic zone. So this is machine learning applications. One is intraoperative differentiation of the tumor and brain tissue. And another thing is prediction of the future intracranial pressure. So the advanced neurosurgery of the latest era is such kind of the micro vascular and also with the 3D system, 3D exoscope. So this is exoscope, the digital 3D CT. The recent we used for not only the very superficial one, but also the deep, the clipping surgery. So this is very simple, light, easy to move, and this is just camera. This is exoscope. It's really simple, but the resolution is not the same as much as microscope, I think. But this is one of the future, I think, tools for the operation. And also the intraoperative, such kind of the navigation, and also the image is another very important thing. So simulation training is such kind of the ventriculostomy placement and brain tumor and the resection and the pediatric pedicle screw replacement, endoscopic transsphenoidal surgery, and endovascular surgery. So these can be the simulation, the training. So this is virtual reality, the simulation. So this is a vascular, and this is with some pathology. And also this is another virtual reality in the OR. And also the robotic neurosurgery. This is the challenges of the improving of the accuracy, speed, and safety of the minimally invasive targeting of the deep brain regions. So it's coming up very soon. So the gender gap in the neurosurgery steps to women empowerment. So this is a global neurosurgery map. So this is how many neurosurgeons is existence in the world. So the Africa and also the North America, the Canada, and some part of the Latin America is limited, the neurosurgeons number. On the other hand, Japan is very green. That means too much neurosurgeon. Now it's 10,000 neurosurgeon, and 70% is board certificate the neurosurgeon. And the female neurosurgeon is about 500, but still just 5%. It's a very limited percentage. So this is a female neurosurgeon around the world by countries. So you can see the European country is most frequent female neurosurgeon. Do you know this country? This is Uruguay. So Uruguay is among the Latin America is the highest number. So in Europe, it's Italy, the most highest population is 36%, El Salvador and Germany, Denmark and Finland. In Asia is Nepal is 7.1%, and the smallest number is Korea is 1.7%. In South America is, I talked, Uruguay is that 1/4 is a female neurosurgeon, many female neurosurgeon. So North America is El Salvador and Honduras is about 10%, and the United States is 7.8%, almost similar to Japanese. And under representation of the women neurosurgeon, four things is very important: surgical practice, and also the congress, and funding opportunities, and also the academic publication. So this is one case. So the daily the clinical work, we should very train and accumulate the cases. So just we can, according to the learning which we started from ABC, so how we can preserve of the perforating arteries of the adjacent to the vaginal tip, the aneurysm. We should avoid the damage of the brain and also the small of the vessels. So that is very essential for the vascular neurosurgery. So this vaginal tip aneurysm a little bit higher position, and with endoscope we can check the whole round of the aneurysm neck, and after placing the clip, when we remove of the perforating artery, which is dense attachment of the aneurysm. So those daily clinical work is another important thing besides the research work. So this is a presentation at the Congress or a conference. The female speakers increased from 1% to the 11% in 2019. So, but the pediatrics was the subspecialty with the highest proportion of the invited female speakers. And this is some of the papers the women publishing. So the 2019 is more papers for female, but still existing the gender, the gap. So this is the first author, and this is the senior authors. And also this is the younger doctors. This is a female first author and the female last author, and also the female the trainees, neurosurgery trainees. It's increasing by the 2019s. And also this is a gender gap, the female neurosurgeons, the funding. There's still some gap, but this is by 2019 is a little bit increasing. And so this is the 2017 to 18, the risen by 6% to 17.8% of the female residents. But overall, the neurosurgery ranked the lowest in terms of the percentage of the female trainees of any medical specialty. So it's a very tough era by the COVID-19. The service for the young doctors through education. So how we can help for the young doctor generation. The goal of the service through education, the supply infrastructure, the local support, equipment, and certification and education programs. So we can tie up with the WFNS, the WIN and the WFNS, and the partnership with the local neurosurgical societies and the WFNS for curriculum and the milestone standards, and the combined educational offerings such as the boot camps and program for the exchange of the educational opportunities and travel to their days partners. This is a kind of fellowship. 3 months, 4 months is fellowship opportunities. And the local neurosurgeons the working on the modernized communication and the conference, real-time conference, and patient discussion across the world, and the intraoperative consultation through the screenless visual communication of the intraoperative endoscope or microscopic surgery. So the understand the infrastructure, the challenge. So this is so many lady neurosurgeons exist in the world. This is Spain, this is Boston, this is Mongolia, and this is Uruguay, which I talked. And also this is again Spain, and this is Taiwan. And also the female doctors gathering, which was held in Dubai, and also Nepal, and also Karachi, Pakistan, and also the Kazakhstan, and also the Morocco. And also the Africa, I impresses because so many female doctors, they are very vivid and they are very active. So this was during the conference in Senegal, 2008. And also the Sudan, I visited 2009, the many lady neurosurgeons. So this is a WFS course. It was held in Sudan. And this Algeria is one of the most female doctors gathering in the country. And now is WFNS current winner chair is a female. And that was Peter Black era. In 2013, I went to the Senegal, the Tanzania. I did one gripping surgery. And at the time, so many lady neurosurgeons. And this is inauguration in India, the female association inauguration 2017 December. It was nice inauguration. So during the conference. So the India, when I visited the first time, it was just one or two lady, the doctors. She did not only the neurosurgery, but also the neurology. But 2017, its number is increasing. So many, the young female neurosurgeon gathered at the time. Avida Shah was one of them. The work-life balance in neurosurgery is very important. Already the Sharon that she mentioned. So there are two important things. One is achievement. The other one is enjoyment. So achievement is, of course, conquering and the winning something, and also an accomplishment. So enjoyment is pride or satisfaction or happiness, a sense of the well-being and all the joys of the living. So work-life balance is the self, the family, and the work and friends. So the 24 hours, how we can divide the time for which is more important at that time. So this is much has been done, but there is still much to be done. So we can see the wider view, the beautiful view when we can reach the top of the mountain. So thank you for your attention.
Thank you very much, Professor Yukukatu. Thank you very much for this great talk. Actually, we are honored to have such a very impressive presentation. Omar?
Thanks, Professor Katu, for this well-illustrated presentation and for your valuable contribution and your endless support. Thanks a lot. May we call Dr. Heba Azzouz. He's a fellow of neurosurgery. He started his fellowship in the ancient university for 3-4 years training, and she finished her master's degree, and now starting her MD degree in Cairo University Neurosurgery Department. Welcome, Heba. She will speak on the outcome of pallidotomy in dystonia. Are you ready, Heba?
Yes, thank you, Professor Omer, and thanks, Professor Nosif, for this opportunity. I couldn't thank enough Professor Yoko and all the panelists for their attendance. So we would like to share about the outcome of post-ventral palidotomy in the management of dystonia. It's a very compact issue and has a lot of details, so I hope time would be saving on my side. So this work was done under the supervision of Dr. Hisham, Dr. Ziad Yusri, and Dr. Sam Hefni from Ain Shams University. So primarily we go through a quick assess or the paucity of voluntary and involuntary movements. It has been divided first into hypo and hyperkinesia. The most common hypokinesia we know is the Parkinson. The most common we know about hyperkinesia is the essential tremors, and dystonia is our main focus. It's primarily introduced by Oppenheim in 1911 as dystonia musciform deformans. And then the definition came more clearly in 1984 as a sustained muscle contraction, frequently using leading to twisting or repetitive movement, and with a prevalence of 19 to 100,000. So the physiology of the basic ganglia is very intertwining and it's very detailed. So an amplitude of the muscle tone. The main entry point to the circuit of the basal ganglia, we can say it's the striatum or the subthalamic nucleus. GPI and SNR could be considered as the main output of the basal ganglia. It has a lot of interconnection, but there's a direct connection. It's mainly therefore turning up the movement, increasing the excitatory thalamic cortical impulses, or the indirect pathway, which decreases the muscle tone and turns down the movement. And also there's a hyperdirect connection. So we don't have the time to go through all these details, but the pathophysiology of dystonia isn't just abnormality in the basal ganglia. It's a very intertwining and it's a multi-level dysfunction or to the peripheral nervous system on the neuromuscular junction. So the classification of dystonia could be recently classified in two axes. First axis is dependent mainly on the age of onset and has a very important identification point. Or the body distribution, we will give some examples, or whether it's associated with other features. The second axis, it's whether it's primary one, mainly genetic, could be a different kind of genetics, predisposition for a movement disorder, or is inherited or acquired due to secondary infection or secondary metabolic disease as Wilson. We will also see this. So some types of the focal dystonia, it's like oral mandibular or plethora spasm. We have the writer cramps or the musician cramp. We have also the cervical dystonia. All of these are focal. Our main focus are the generalized dystonia that contribute to all the body. The management of dystonia is a very important thing. It's not a one-disciplinary approach. It's a multidisciplinary approach. It has to have the physiotherapy, neurology, pediatrician, and neurosurgery presented lately due to misdiagnosis of the dystonia. So the diagnosis, as we said, it could rely a lot on the history, whether there's any prenatal incidents or any cause for leading to a secondary dystonia. Examination to the patient is crucial. It helps us also to identify the reason behind it, whether it's a motor examination, sensory, and sometimes we use ophthalmology consultation to see the Kaiser-Fleischer ring and Wilson disease, which is increasing in the copper in the serum and the urine. So in the investigation, we would use the lab to see the copper, cerebroplasmin, and the urine and the blood. Investigation, most of the time the MRI could show a normal MRI, especially for PECAN. That's the different thing. We would have to see in the image in the MRI here, it's called the tiger eye phenomena. It's very descriptive for PECAN, panthenate kinase deficiency, and it's one of the forms of primary dystonia. Then we would use the scoring scale, which has more of a prognostic rule, so we could see if the patient is improving or not. It's relying on the different body organs with a provocative factor and a severity factor for each organ. The maximum number is 120, and So diagnosis, as we said, important point in managing the dystonic patient. The treatment, I just want to highlight a very quick point is that in children, we would rather recommend for the insertion or the introduction of levodopa that has a significant results in primary or children in reduced dystonia. There's other different kind of approaches, whether it's intrathecal baclofen, chemodenervation. It's mainly used in a focal dystonia to inject buttocks to decrease the muscle contraction. So it's used mainly in a focal dystonia, sometimes in cervical dystonia as well. Unfortunately, we cannot combine all the medication or all the surgical intervention in one word, but in a surgical approach, we would have to divide it into central or preferred. Central is our main whether it's ablative or stimulation. So subventral is ablative ablation. So what's the main rationale of the surgery? Ablation, stimulation is like the deep brain stimulation, and here's a picture of it. The rationale of the stereotactic surgeries is actually mainly to disrupt the abnormal circuit in the basal ganglia or the interconnection of the corticothalamo-spinous tract. So disturbing the circuit at any point could actually abrupt that abnormal movement, but why we choose the target? So we choose the VIM, mainly in tremors, we would choose the globus pallidus interna, mainly in a decreasing of the muscle tone and on the movements. And that's why our main focus is in GPI. So our method, we had 12 patients in generalized dystonia from 2015 to 2017. All of them had bilateral pallidotomy. Not to forget to mention, they didn't have the bilateral pallidotomy in the same session. We prefer to have it in a separate session, also to help us in assessing the improvement of the patient. So what are the steps we had? First of all, we had the stereotactic frame application that was used to assess meticulous targeting for the GPI. Prior to the frame acquisition, we had the MRI. It's a 3D volumetric MRI. And then we do the CT after the frame insertion, and then we do CT MRI fusion as seen in the picture. We fuse both images for more localization of the target. So how do we choose the target? First of all, we could consider that that's very compact and very adherent to other vital structures. So it's meticulous planning is a very, very crucial important point in achieving an outcome. So the GPI, we could say it's the interpoint between the anterior commission and the posterior commission. That axial view isn't really accurate, hence the AC and the PC does not present in the same axial line. But this is just to get the picture more clear. Also, we could use a stereotactic atlas after applying the CT MRI fusion, which is called the Sharon-Varon atlas. And those are images of the planning done preoperatively. The red dot presented in the screen here is the target lesion, and we have a confirmation with an overlying atlas. So we use the two kind of frequencies. We start with the low frequency to assess the proximity. We would use it also to the patient if they are sedated and cooperative. We will ask them to move their hands and to make sure that we're not injuring any vital structure, such as the internal capsule, for instance. And then we increase the high frequency and we ask them if they have any visual pictures or any flashes or any speech dysfunction to make sure that the lesioning is done correctly. So this is the lesion, the machine, and we had the lesioning at 70 to 80 degrees Celsius for 60 seconds. And then we had 3 consecutive lesioning. We move craniocaudally, as we see in the picture here, like the lesion is 2 millimeter difference going up. So we can start down and then start going up with the electrode 2 millimeter differences. And then we have 3 consecutive lesioning. So our outcome was we had 12 patients. There were equal number of sexes, female and male. That doesn't have any statistical significance. The age range was from 7 to 28. We had only 1 case, which is primary dystonia, and 11 cases were actually secondary. 1 was pecan, which was called with a genetic. And we had a Wilson, 2 Wilson cases, and 8 cases was cerebral palsy due to whether hemorrhagic or infection in the prenatal insults. And all of them had bilateral. Some of them had sedation, and some of them had general anesthesia. So that's the chart to give you a clear image about the outcome. The blue is the preoperative, and the red is the postoperative outcome, according to the BFM scoring of the dystonia scale. So the overall improvement was around 41%. And that was a statistical significance of 0.01. And then we had the primary dystonia, 55. Secondary dystonia, whether it's to prenatal insult or to metabolic, as we said, the Wilson or Pecan, is 0.004 point. With a statistical significance. The male and female ratio didn't show any statistical significance we only had one complication, and that gratefully was a transient complication of speech alteration that improved automatically after 3 months. We didn't have any injuries of CSF leak or hemorrhage because we have to make a very meticulous planning while setting the electrode not to go through the ventricle or not to go through a sulcus. Here's the case of this 70-year-old patient presented with the status dystonicus. As you can see, ICU. That's me. The patient now could actually walk supported. He had bilateral palidotomy. And another case, this is a 9-year-old male. He had a bilateral palidotomy. This is the preoperative video. He had more an oral mandibular dystonia and also in the upper limb. Post-operative, patient resolved this. That was after the second palidotomy. We said we don't do them in the same session. So the discussion, we had 12 cases. Their improvement, the mean improvement were about 41%. That's a satisfying number. Putting in mind that most of them were presented with a CP and they had already a contracture and posture abnormality. Putting in mind also the literature from 1996 to 2007, the cases were published for palidotomy in dystonia were 29 and 40. Whether it's primary and secondary respectively, with a BFM score of improvement around 61%, according to Grossi et al. And according to Ondor and Yeshua in literature, the improvement were about 31 and 57 to CP and to metabolic insult respectively. We have to put in mind in assessing the palidotomy in generalized dystonia that the improvement is actually delayed because we need to rely on the neuroplasticity of the brain to change and for the rewiring and for the relearning of the tasks. Whether it's unilateral or bilateral, that's not documented in the literature, but we could say that bilateral take the upper hands for two things. The interconnection between the two basal ganglia, between the lenticularis fasciculus and ansa lenticularis. So when you have a bilateral palidotomy, we abrupt this connection, and increasing the number of the lesion and increasing the size lesion also are advocated in Morayal literature for having a better outcome. The earlier intervention took an upper hand because the delay of the contracture and delay of the posture abnormality and the early prognosis of the dystonia leads to a better improvement. I think I'm taking a lot of time. Deep brain stimulation versus palidotomy. It takes the upper hand because palidotomy takes the upper hand because it doesn't have the complication of the DBS of hardware or malfunction or infection. So the conclusion is bilateral palidotomy is shown to be very safe and effective if we had a very meticulous planning and we have a proper patient selection for the dystonia patient. Thank you. And at least I want to thank Professor Yoko for being there for her support. And thanks a lot.
Thank you very much, Heba, for this very, very wonderful presentation. I'm very happy that we started to show some of scientific presentations from Egypt, from our women in neurosurgeons in different centers, especially in the presence of Professor Yukukatu and all attendees, either from Asia or from Africa, from all over the world. Our next speaker will be Nihal Shaaban. She's consultant neurosurgeon from Tanta University, Cairo, Egypt.
Yes, thank you, Professor El-Ghandour, and thanks to Professor Omar and to Professor Yukukatu and all guests. And thanks for this great chance for the Egyptian woman neurosurgery. Thank you. I will speak about a talk titled Selective Cervical Discectomy Guided by the Result of Ultrasonic Selective Nerve Root Block. sorry, I have.
Unmute your mic, Yanihal.
Okay, sorry.
Unmute your mic.
Okay, multi-level disc degeneration present in almost 60% of people who were more than 40 years old. Sorry, doctor, I will share the presentation from another lab. Sorry. Sorry, multi-level. Okay, Dr. Omar. Multi-level disc degeneration present almost 60% of people who were more than 40 years old. Positive MRI finding occur in up to 60% of asymptomatic people. MRI provides only the morphological information, but may not tell the actual clinical significance of the finding. Patients complaining cervical radiculopathy due to multi-level pathology on imaging studies are still associated with moderate surgical outcome. Although multi-level surgery may result in an initially good surgical outcome, these patients later may have a higher predisposition to pseudoarthrosis and adjacent level degeneration due to loss of normal biomechanics. The pseudoarthrosis incidence increased with the number of ECDF levels ranging from 0 to 4.3% for one level up to 56% for 4 level diffusion. So in these patients, operating upon the affected levels only will give better surgical outcome. Selecting the offending level depends on a precise preoperative diagnosis and localization of the affected root, which are often difficult to define from clinical symptoms and MRI only. Electrophysiological studies are commonly used in the diagnosis of radiculopathy in questionable cases, but a rather common problem is the discrepancy between normal electromyogram studies and abnormal MRI and vice versa. MG-guided cervical nerve root block is commonly used in a symptomatic patient to confirm the pain generator and decrease the severity of pain after failure of medical treatment and physical therapy. In this study, we used the ultrasound-guided selective nerve root block as a diagnostic preoperative tool to determine the affected root in multi-level cervical pathology. By reviewing the literature, there were 3 studies utilizing the same idea of surgical level selection guided by the results of preoperative selective nerve root block, but under fluoroscopy guidance. Up to our knowledge, this is the first study utilizing the ultrasound-guided selective nerve root block as a preoperative diagnostic tool for selection of surgical level in multi-level cervical disc patients. The first study by Anderberg et al. 2004 titled Selective Diagnostic Cervical Nerve Root Block Correlation with Clinical Symptoms and MRI Pathology. They conclude that selective nerve root block seems relevant for revealing a relationship between MRI pathology and the clinical symptoms and signs in patients with single-level disease. He published another study in 2006 and titled Selective Diagnostic Nerve Root Block for Evaluation of Radicular Pain in the Multi-Level Cervical Spine Disease. They conclude that clinical symptoms and signs isolated or combined with MRI findings are not always a reliable parameter when selecting pain-mediating nerve roots in degenerated cervical spine patients with radiculopathy, and concludes that selective nerve root block seems to be more useful for selecting pain-mediating nerve root. Seso et al. Published a study in 2005 which titled Selective Nerve Root Injection Can Predict Surgical Outcome for Lumbar and Cervical Radiculopathy, and they conclude that a diagnostic selective nerve root block can safely and accurately discern the presence or absence of cervical or lumbar radiculopathy. The ultrasound-guided selective nerve root block has many advantages over the fluoroscopy guidance: easy accessibility and cost-effectiveness, lack of radiation exposure, no need for dye injection, visualize the vessels effectively using the color Doppler ultrasound. It is an extraforaminal approach with high selectivity and safety. This technique includes the neurological examination and assessment of the arm and the neck pain on the visual analog scale, pre and 30 minutes post the block, with certain precautions. Analgesic stopped for 12 hours. No local anesthetic will be used to the skin. No corticosteroids used, only lidocaine. At least 4 hours had to elapse between the first and the second block. The patient lie on lateral declovitus position with symptomatic side up. Samsung Ego H60 linear probe, 7.5 to 16 megahertz will be applied to the symptomatic side of the neck in a transverse plane after aseptic skin preparation. The main landmark are transverse process. This is extraforaminal approach between the nerve root and the posterior tubercle. Cervical cervical root leveling. The C7 transverse process is identified by rudimentary anterior tubercle and prominent posterior tubercle. The nerve root is visualized as an oval hypoechoic punctate structure anterior to the posterior tubercle in close relation to the vertebral artery. The C6 transverse process is characterized by its sharp and larger anterior tubercle. The nerve root is visualized as an oval hypoechoic punctate structure between the two tubercles. From C3 to C5 vertebrae, the transverse process is characterized by two identical tubercles that produce a U-shaped fish mouth or two-humped camel sign. On the sonogram, the nerve root is visualized as an oval hypoechoic punctate structure between the two tubercles. The vertebral artery is best visualized at C7 vertebral level because of the absence of the anterior tubercle of the transverse process. But at the other levels, the vertebral artery can be visualized in the space between two adjacent transverse processes using the sliding maneuver. After the targeted nerve root was identified, a 22 gauge needle will be slowly advanced towards the oval hypoechoic target. The needle is inserted just lateral to the transducer and advanced from posterolateral to anteromedial with an in-plane approach. The needle tip is placed between the nerve root and posterior tubercle outside the intervertebral foramen. This approach is extraforaminal approach, providing a margin of safety. Once the needle tip was in ideal position, 1 milliliter lidocaine, 1% will be slowly injected. If the patient reported a subjective arm and neck pain reduction with a corresponding visual analog scale reduction of 50% or more, the root was classified as significant for mediating the radicular pain. This study was designed as a prospective one conducted between August 2017 and April 2020 on 30 patients with multi-level cervical disc disease presented to Neurosurgery Department, Benha University Hospital, Egypt. They had undergone selective ACDF after using the ultrasound-guided selective nerve root block as a preoperative diagnostic tool for detecting the affected root and its impact on surgical outcome. This study includes patients with multi-level cervical disc disease presented with unilateral radiculopathy after failure of conservative treatment, and exclude patients with more than 2 roots affected based on the ultrasound-guided selective nerve root block result, presence of myelopathy, patient with ossified posterior longitudinal ligament, medically unfit patient for surgery. All included patients were suffering from upper limb radiculopathy with failed conservative treatment for at least 3 months. The degree of pre-block pain was assessed by visual analog scale. Ultrasound-guided selective nerve root block was done 1 week before the planned surgery. ACDF was done for the selected level, guided by the results of the block. Arm and neck pain were reassessed by visual analog scale on 1 day and 2 weeks after surgery and were compared with the pre-block pain. Case number 1, male patient, age 50 years old, presented with left brachialgia with failed conservative treatment for 1 year. MRI cervical spine showed 3 pathological levels, C4-5 level, C5-6 level, and C6-7 level. Neurological examination and visual analog scale of the arm and the neck pain was assessed on pre and post and 30-minute post block. The block was done for the C7, C6, and C5 roots. C nerve root and vertebral artery were identified, confirmed by the color Doppler before injection. Arm and neck pain visual analog scale reassessed. The arm pain decreased by 37% and the neck pain decreased by 16%, which was considered negative. After 4 hours, the block was done for C6 nerve root. Arm and neck pain visual analog scale reassessed after 30 minutes, and the arm pain visual analog scale decreased by 60%, and the neck pain decreased by 50%. And this is considered, which was considered significant for mediating the arm and neck pain. After 4 hours, the C5 nerve root block was done. Arm and neck pain visual analog scale reassessed after 30 minutes. Arm visual analog scale decreased by 75%, and neck pain decreased by 50%, which was considered significant for mediating the arm and neck pain. This is a video illustrating the injection of the C6 nerve root. This is the C6 root, and this is the trajectory of the needle. This is the needle, and this is the 6th nerve, and this is the posterior tubercle, and this is the anterior tubercle. This is the injected material with the expansion of tissue. Guided by the result of selective nerve root block, we do surgery for C4, 5 and C5, 6 levels. Only the patient was reassessed in the next day of surgery and 2 weeks later for neurological state and arm and neck pain visual analog scale, plain X-ray and AB and lateral view were done. The arm pain visual analog scale decreased by 85% and the neck pain decreased by 75%, which considered a good surgical outcome. Another case number 2, female patient, 50 years old, complaining of right brachialgia with failed conservative treatment for 1.5 years. MRI cervical spine showing C3-4 level, C4-5 and C5-6, C6-7. Arm and neck pain were assessed on the visual analog scale. We did surgery guided by the result of the selective, we do the selective nerve root block as the same manner, and we do surgery for double level only, C5, 6 and C6 levels only. Guided by the result, postoperative arm pain decreased by 75% and the neck pain decreased by 50%, which is constant. Our result, the age of the patient ranged between 34 and 59 years with slight male predominance. The duration of symptoms ranged between 3 to 24 months with a mean of 13 months. The clinical presentation, all patients present with complaining of upper limb radiculopathy. 27 patients had neck pain and only 5 patients had weakness. Out of our 30 cases, 16 patients had 2 pathological levels in preoperative MRI, and 14 of them had single positive root block and undergone single ACDF, and other 2 cases had positive root block and undergone double level ACDF. 11 cases had 3 pathological levels in preoperative MRI. 6 of them had single level root block and undergone single ACDF. And the other 5 cases had 2 positive root block and undergone double level ACDF. Only 3 cases had 4 pathological levels in preoperative MRI. All of them had positive double level root block and undergone double level ACDF. Comparing the arm pain visual analog scale post block and post surgical, we found that the pain reduction was better in post surgical than post block in 15 cases, and both were equal in 14 cases. And in 1 case, post surgical pain reduction was less than post block pain reduction. The degree of neck pain reduction, either post block or post surgical, was less than the degree of arm pain reduction in most of cases. This may be explained by early evaluation before occurrence of fusion and residual other level degenerative changes. No mortality in our study group and no complication from ultrasound guided selective nerve root block. Only 1 patient suffered from dysphagia and hoarseness of voice due to right recurrent laryngeal nerve palsy from traction during surgery that was managed conservatively. We conclude that selected ACDF guided by the results of ultrasound guided selective nerve root block gives a good surgical outcome, indicating the high predictive value of ultrasound guided selective nerve root block. We are against the use of selective nerve root block as a diagnostic tool in single level clear cut cases of radiculopathy. However, in cases where MRI findings are multi-level, equivocal, or don't match with the patient's symptoms, the predictive value selective nerve root block is significantly better than MRI. Thank you.
Thank you, Dr. Nihal, for your this interesting topic, and I think it would be a very strong impact on preparing surgery or just to follow surgery. It's a very interesting topic. Thank you, Dr. Nihal. Now we are going to open the discussion. Hello?
Omar, do you have any questions or comments in
Yes,
the chat panel or in the Q&A?
So can I ask the doctor?
Yes, well, welcome. Yes.
Oh, okay.
Yes, welcome, Prof. Yes, please.
Okay. So thank you very much. So I don't know how much percentage you have some kind of those diseases, because it's quite rare, and also in Japan we have such kind of dystonia, the deep brain stimulation surgery we perform. So do you have many cases?
Dr. Hiba, please
Yes.
answer
Yes.
Professor Kat, please.
Thank you so much. Professor Yoku, actually, we don't have an exact number due to some proper documentation of the cases, but we could say that the rate of CP is high. The prenatal insults or the perinatal insults are actually quite common in developing countries. So a lot of the cases, as we see, like 11 of them were secondary, and 9 of them were secondary to CP. So hence the rate of dystonia is quite prevalent in Egypt, and I think in developing countries. We had some cases that had deep brain stimulation, but most of the patients cannot afford the price of the battery and the maintenance. And we once had a child that she had a status dystonicus due to issues in maintaining the battery. We cannot actually get it from abroad. And then the patient used to suffer for a logistic reason. And that's why we in our department would recommend palidotomy as a very cost-effective surgery for developing countries, and also for who cannot afford the DBS. And considering the option of having the bilateral palidotomy not in the same session, but actually with quite 3 months differences, help us in assessing the outcome. And if the patient is cooperative and he's sedated, we start with a low frequency dosage, and then we avoid the proximity of any motor vital structure like the adrenal capsule or the optic tracts. We're assessing and asking the patient if there's any visual flashes prior to doing the actual lesioning, the permanent lesioning. I hope this answered the questions.
By the way, just I want to ask how developed in Egypt about the prenatal neurosurgery.
Perinatal neurosurgery is that like
Yes.
intrauterine intervention.
Yes.
I would leave the comment to my professor, but for my small knowledge, I don't think it is there to start with assessing it.
Thank you. Thank you so much.
Thank you.
Very good paper. Thank you.
Thank you a lot. Thanks for your feedback.
Thank you.
May I ask Dr. Sharon, please? Dr. Sharon, are you here?
Yes, I'm here.
I would like to thank your very interesting presentation and your interesting long journey as well. I would like just to know the difference in cultures between your country and other countries regarding the females when they think in a neurosurgery residency or neurosurgery training. Do they consider the neurosurgery training in your country is one of the difficult training type, and they don't like to participate in that, and they do prefer another medical training? or what is the difference, please?
Okay, my country is basically, I think, a normal Asian country with, the system is the same. We have family support and, the religious background and things like that. I think because in most of the centers in our training centers, we have a women neurosurgeon in the training center. So even in my center, I am one of the trainers or supervisors. So even if we have female residents in our program, we treat them similar with the male residents. And to me personally, I don't think there's an issue. So that's why we are getting more female residents that are joining in, for more women who are joining neurosurgery, because they are seeing the trend and they are beginning to realize that there's not much barriers to challenge them or make it difficult for them to take up neurosurgery as a career. So I think in almost all the centers, we now have women neurosurgeons. I mean, public hospitals, we have women neurosurgeons. So they are actually a sort of a benchmark to any neurosurgeon or any neurosurgery resident that wants to join. I don't know, see, I think it's getting simpler and easier for them, because we are there, like I'm in my center, and I make sure everyone is given the equal treatment, including male and women. And to be honest, I think a lot of the problems are not just from women residents, they're also a lot from the male residents. And I think now in this present generation, or the way the world is, even men are taking up responsibility of taking care of their children, things like that. So I do get requests from my residents, can I take time off? I need to take my wife for her medical checkup, so I think it's about the same. I don't think there's much difference. And it's important for women to play a role. If you have women neurosurgeons in your country, it's important for them to play a role and to sort of give the women some credibility in their environment.
The culture and the situation in our country is still little bit different, that the woman and the female is the main cornerstone of the home and the family. That's why she should combat between family, home, and the hard work in neurosurgery. Unless they will get encouragement from the family, the husband, the other members of the family, it will be difficult for them. I think this is the difference.
Because Malaysia background, I mean, if you talk about religious background, we are the same. About 70 to 80% of the population is Muslim. But if you're talking about cultural background, where you're talking about Malays, Chinese, Indian background, it is also the same. The parents and the husbands usually are the ones who are more in control. But I think maybe because of development of the country, because of financial requirements, I think even parents are becoming more broad-minded. They want their daughters to also have careers. You have a son, you have a daughter. I don't think you can prioritize this, my son having a career. I'm sure a lot of the male neurosurgeons here might just have daughters. I'm sure you want your daughters to do something also, and have a career for themselves. So I think the support is also coming from the parents, because even the children needs to, she wants to go on to do a neurosurgery. And if she does get married, I think the parents are willing to support and, take care of, helping out. So I think that's what's changing now. I think parents want more from their daughters, not just from their sons.
Dr. Nasser, what do you think in that?
Sharon, my daughter was graduated just a few years from Cairo University, and she was on top of class, getting very good scores, and she was looking for dermatology. I asked her, why don't you take neurosurgery to be resident in Cairo University? She have seen me all my life. She didn't see me except very few times, working all the time, working almost sometimes very, very long hours every day. I'm surprised how this generation is thinking. They always looking to take the easier way, and most of them. But I'm very happy that now we have our women or our ladies. They are taking such challenge, because I totally believe that in order to be successful, you have to take a specialty which you like. You are going to sacrifice a lot of time, I know, and a lot of efforts, sacrifice some of your health. I understand this. But at the same time, in order to be successful, if you like neurosurgery, you will take it. Neurosurgery is an art. Not all the people are interested in this art, but people who have very, very high talent or high taste about what we are doing, they will like it. I'm sure if we start from the students, they go to operation room, they see neurosurgical operations. That is the stage at which they become interested in our specialty. And when they become house officers, they could have some training. I don't know if Professor Osama Al-Ghandour is here.
Yes.
Professor Osama Al-Ghandour, he is dean of the faculty of former dean of faculty of medicine at Azhar University and honorary president of Egyptian Society of Neurosurgery and former chairman of the Department of Neurosurgery at Azhar University. Thank you, Professor Osama, for joining.
Hello, everybody. Delighted to hear, especially women's neurosurgery. That's very good. But there is one point which is really probably not inviting the women neurosurgeon in our countries or probably in whole Middle East, is that patients, they prefer men neurosurgeons. That's why probably ladies refrain and they are not very rarely accepting or going to neurosurgery. I think we have to encourage the ladies. Some of them, whom I know them personally, they are very strong, they are fighters, and they are doing very well. But I think it's a long way to have many women neurosurgery. But still, we need to change the culture or the concept on the common people. And it's not only neurosurgery. I mean, if you look at the gynecology surgery, women's, there are good number, but they are not working very well in the work because ladies, although the ladies, they prefer to go to a men gynecologist, not a lady gynecologist. Probably these are miserable facts in our societies. But anyway, that's very good. I'm delighted to hear all of you, and God bless you, and just keep doing as much as you can to encourage women and neurosurgeons. Thank you.
Thank you very much, Professor Osama Al-Ghandour, for your contribution. You are always following our webinars and contributing and honoring us by your contribution. Thank you very much. I think it's time to proceed to our next speaker for the...
Dr. Nasser, I have a question to Dr. Nihal.
Say again, Rabab, what you are asking about?
I'm asking Dr. Nihal a
you have
question
a
about...
question? Yes, please go ahead. Okay.
Okay, Dr. Nihal, can you use your technique to assess recurrent or only de novo cases? And the second question, can you use it to assess post-operative cases or not?
Yes, but in this study, all cases are de novo. I hadn't any case recurrent, but this may be in next study.
Okay, thank you.
Thank you. Thank you. Our next speaker will be Professor Kostadin from Japan. I think we have still very interesting presentations. And our next presentation is about current trends in neurosurgical training, ideas and realities.
Oh, yes, thank you very much for having the chance to speak. I will just briefly try to present some impressions about the current status of training around the world. There is no need to introduce so much about the importance, about the details and the challenges that training is: high cost, complexity, social aspects with a lot of impact because of disability. So in all that, I just focused on 3 points. The first is that is really our training system matching the requirements of the healthcare system, which demands the neurosurgical care practically in a reasonable, acceptable time that is planned? And then, are the number of neurosurgeons really sufficient and properly planned and distributed? And finally, how the system itself is able to improve intrinsically. I mean, it is having an embedded system to improve. So from ideal to practical things, actually what we need is adequate performance at the end of training, adequate number of trainees graduating, certified and practicing, and finally, how the system is updating itself and it is progressing in that. Well, what are the impressions in general in the real world? I mean, a lot of questionnaires, statistics, and quizzes done through different groups and even published. There is an increasing demand for training time. There was also reduction of the working time in Europe, in the United States, so time is getting shorter. There are significant differences among the countries. I mean, we have huge discrepancies at certain points. There is a constant increase in the complexity of the cases that have to be managed to the residency. And finally, the neurosurgical and neuroscience knowledge is booming. It is expanding. So we don't really are able to catch up with this expansion. Let us look in a little bit, a short look in what we have in Asia. Big differences. Japan is a leader in the numbers, as Professor Kato mentioned, more than 10,000. At the same time, we have some numbers that are indicating pretty slow growth. These were data in 2020, actually, maybe 2019, which are giving single-digit numbers of growth for Indonesia and Malaysia, which is very confusing and indicating some discrepancies that we cannot always explain. Oops. All right. So what we have to really look for and observe at the end of the training when we have to certify the candidate. This is practically the end of a long period of training with some kind of formal examination, which is having already well-established content. But the impressions after going out in the real world are that there is a little bit of suboptimal performance, and not always a little bit, sometimes really much more difficult, particularly if practice is not in a big center. And also the range of activities and techniques learned and applicable knowledge is not as it has been during the residency. Usually residents move from big centers to a small one. So is really the board doing the proper assessment? Probably it is, but most of the role is to guarantee some safe practice. Whoa, it's not moving. Well, how these things are solved in different parts of the world in different way, but what we have to look at are the three main components of teaching, which is accreditation of teaching, the programs, and finally, the process of certification. How they really do look like in different places and what we can learn from the observations. Accreditation is the selection of the centers and the places where the programs have to be allocated. In some countries, they are somehow self-determined because of the prominence of certain teaching institutions, medical institutes, faculties, universities. But in general, it is some kind of determination by the neurosurgical associations on one side, and on the other side is the health administration or some kind of authorities that exist. So the number of residents further on are decided on not always on some rational, well objectively defined basis, but more as estimations and requirements that are self-imposed by these institutions. Objectively having to look, we can look at the American system of the Accreditation Council, which is giving clearly number of, let us say, admitted patients, number of outpatient visits, number of operated cases, number of qualified teacher from certain level above, and so on. And that will also determine the number of residents. And some important universities even have only one resident per year. So that should not be something strange and even discrediting. So let us go on the other details. In general, the programs have a broad neurosurgical subspecialty coverage, exposures to clinical cases as much as possible as is given to the residents, and even if possible, given the clinical and the basic research opportunities, because they have to be able to apply evidence and able to match their activity with the existing evidence. So constantly evolving through these paths and periodic evaluation is something very often observed in the training program. In that standard methodology of training, like the Cobb cycle, I will say, this is the standard relationship between apprentice and master that we know for many decades in neurosurgery. This is the observation of the procedure, reading and learning about it, performing it supervisedly, and then performing it maybe unsupervised. But that cannot be with one cycle. Sometimes the learning curve is not steep or steep enough. We have to repeat the learning process in a big number of times to achieve. A similar common approach is the Miller's pyramid, but I think that is more broadly applied now, and we can see it, let us say, in the American and Japanese and the other big, well-defined, detailed programs of learning. In fact, this is an evolution from just knowing the basics to the becoming an innovator at the top. But for certification, we need the level just below, which is unsupervised practice. In this way, we really have the safe practicing neurosurgeon regarding certain kind of pathology. Well, these are, I will say, pretty basic things. Just how that applies to the, for instance, the AANS and the certification in America, they have been using a matrix project for many, many years, and the definition of the minima that are required to be certified have been clearly expressed. We had also the Milestones project, which is also well applicable into the undergraduate teaching. So it is a way of a good measuring system, but it is somehow rigid at certain point. Here, at the top, we have the same as the Miller's pyramid, so nothing particular to wonder about. This is, for instance, the level 4 for aneurysm surgery. Simple aneurysms are operated by the resident. That is a passing level for board certification, nothing. On the level 5, he's already able to mentor and is making the most complex cases. In EANS, the European Association is little more discordant, because the overall organization of independent countries having common standards is very difficult to be matched. And we have variability in the residence programs, in spite of the common initiative of the European Association, but that has not been yet fully implemented, unfortunately. Also, there is a little bit of domain of practice discrepancy where we have vascular surgeons, clinical neurologists, or neuroradiologists doing endovascular, orthopedic surgeon operating spine, and such kind of things. That is not rare. And finally, a few words about Japan. We have to know that probably it is more similar to the American system. We have the similar number of years, but the first 2 years are more like an internship. And definitely we have a fixed number of required cases before the accumulation of which this resident will not be able to graduate. Finally, all the examination consists of a written MCQ and written test, and then some case practical experience. So it is a two-stage examination with clear clinical practical scope on the second part. Well, just to summarize, big variety. We had in India, or maybe still have, 3 years, up to 7 years in certain places. So we really cannot establish some kind of common rules and common principles how to organize the ideal training system at the moment. We have to adapt it somehow. And the neurosurgical societies and the governments and the regulating bodies are trying to adapt it, but I'm not sure that is always efficient. So we have to keep that kind of independence of the balance between accreditation, which should be independent body from the healthcare regulator and the Neurosurgical Association. And the training programs have to have their autonomy as much as. And the evaluation board has not to be the same way represented, let us say, from the trainers and so on. As much as this triangle is independent and independent from these factors on the side, that will guarantee better, let us say, objectivity of the regulation of a program. Some other observation about the numbers. Well, neurosurgical bodies are looking for quality usually. So they tend to reduce a little bit the number of neurosurgeons, while the healthcare bodies want to provide the service to the population. And there is also some kind of let us say, discrepancy in that direction. We have to find some kind of balancing. But balancing has not been achieved. We have such kind of graph, Kato Sensei also showed such kind of thing. These are income, high income, low income, middle, and the number of neurosurgeons. Japan is definitely the highest bar here. But we have read somewhere here in the middle, and even Afghanistan is in the interquartile range, actually in the median. So it is not a very strict rule. It is not strict rule when we see the map also. We saw it already once. You see, Uruguay is doing very well. But New Zealand is red, very low number, and it is a very high income country. So what's going on? Well, returning back to our areas, this is the Southeast Asia and this is East Mediterranean. In these 2 points, we have the biggest neurosurgeon rate growth. So I think somehow these areas are finding their way into development of the necessary neurosurgical care, although slowly, but it is starting to catch up. So hopefully this tendency will be continuing. To summarize that, I will definitely say that to be efficient in that decisions about the numbers, an independent, again, some kind of work group or task force, whatever, will be much more efficient than the constant debate between the different bodies that we have in the country. Well, and the third point, which I would like to say a few words, maybe a little bit faster because it is pretty complex, is the self-improvement. The training system has to be able to self-improve because of the rapid advancement of neuroscience, particularly clinically applied neuroscience. We are in a under constant pressure to improve not only what we do, but how we train. So is that really a well-mastered gradual process? Actually not, and that is not probably possible to be mastered like that, because if we look at the evolution of clinical practice, it is probably applicable, this kind of social science cycle, which is the Kuhn cycle, the paradigm concept. And in the clinical practice, we have the relative consensus on the method of management based on evidence. Then evidence keeps on accumulating, and then there are factors that indicate that it is not working for everybody. And then comes the new methodological evolution to go into a new paradigm. So our training system also is evolving like a paradigm system. That is not strange, and we have to be anticipating that, and we have to be ready to do that with the proper time that is needed, because this is a time-dependent process. And this time-dependent process is at the beginning with the research starting, and then this is the size of the arrow is the intensity. Then we have the increase in the clinical practice, and then we have also accumulating evidence. But the training should be at the beginning of the clinical practice period. And what happens further? Before, it was a slow process. It was less demanding evidence and more regional. Now it's totally the opposite. Globalized, strong high level of evidence, and so on. So let us go on what we have to change. We have to change the contents, the competencies of our residents, eventually the curriculum in some parts, but also at times to change the neurosurgical specialist development path, which means certain number of years after that should be that a fellowship, or we have to do some kind of other structure of the training to be modified. I was privileged to work in 3 different systems, starting in my own country. Then I worked in the Middle East, and now in the last 12, 13 years, I'm in Japan. And I have been evidencing and participating in the process of, this is an example, with vascular surgery when clipping then was mixed with coiling, and then they were strongly competing with that. And then the same with endarterectomy and stenting and so on. So what happened further on? We had clearly distinct paradigms. This was the clipping time. This was the time in which we had coiling and clipping simultaneously developing, and here came little by little stronger evidence of the application, for instance, of intracranial stents, flow diversion, and so on. So we are moving from stage to stage in a relatively rapid pace. What should be our reaction? Immediate update. This is the only way. We have to be strongly observing and putting the hands on our residents on the subject of what they have to learn in the next period of time. When they will be already graduated, it will be 5 years maybe. So after 5 years, all the things that are now trending tendencies will be already somehow necessary part of our practice. And for that kind of catching up, we have been working probably constantly. And the result was a very interesting phenomenon that I would like to share. We have 2 types of neurosurgeons in general, some that went very narrow in a very highly specialized way, and some others had to keep a broader range of abilities and be able to be more hybrid and adaptable to the practice in a smaller institution with more diverse type of practice. And I suppose that this tendency to somehow will continue. Is this really an efficient way to be practicing and delivering neurosurgery to the population? We still have to see. But the single master is limited in number of technique and so on and so on. He has a big team, but with each of them is super specialized and he is a good instructor. But the other person who is a more hybrid type, he has to learn many techniques. And he is good for general or advanced residency training, but not for a specialized one. What can be, I can offer probably some kind of solution in the form of modular training. Part of the residency should be a standard one. And further part of the elective modules that can be put on in the last couple of years can be very important. First, in deciding the future of this resident as a practitioner. Number 2, of making this resident choose what really he wants or she wants to do in neurosurgery. And that is something that can be much easily implemented than standardizing long periods of time. And the second recommendation to the training is always being able to combine interdisciplinary subspecialties. What I mean, we have to do domains of pathology, tumors, vascular, and so on the other side, we handle different kind of techniques. It is very important we handle more and more techniques at the same time, at least two of them, endoscopy and stereotaxis or whatever combination. You can choose open vascular, endovascular. We have already good number of hybrid neurosurgeons in that way. So in that approach, we will be able to produce better neurosurgeons for the broad practice that is needed. Such kind of multifaceted neurosurgeon can be a very useful specialist. Well, a little bit about women, I would like to say a few words because I'm impressed about the Egyptian Neurosurgical Society, and that is an important, crucial step for all ladies who have dedicated themselves to neurosurgery. I congratulate them really warmly. Now, we have a progress in the engagement of women in neurosurgery in the world. For instance, this is a diagram into the progress in the United States, where we have already a pretty good number, a total women not certified only, probably about reaching 20%. But that is not the point of the solution. There have been plenty of complaints before. Numbers are growing. Italy is having 36% of female neurosurgeons finally. Kato Sensei also mentioned the other. So we have already progress. Now, where is the problem? Continuing complaints are lifestyle is difficult. Mentoring particularly, they are the questionnaires are indicating that physical burden and conference representation, all this is still present. But in general, if we take them for a really properly applied training system, there is no conflicting points. So where is the conflict? The conflict is in the attitude. The conflict is in the attitude of the outdated mindset of many other influences. Many of the other speakers already mentioned about that. And what we have to do is get out of that. But how we are going to get out of that? By convincing society, by making those in the neurosurgical house being not tolerated by the society about their attitude. This is the only way when society accepts female neurosurgeons and when the neurosurgeons inside are convinced that that is the proper way. So they don't have support outside. And what we have to do, we have just to show the world, as you have been doing with making a society in Egypt today and in actually this very important moment, that is the point. The society has to know how female neurosurgeons can achieve in the same way as male neurosurgeons, and there is no difference. Are we going to board out of the plane if the captain is a female? No, no. We accept it as the same. The the female pilots, because of the strict regulation, the strict protocol, they don't have any problem and any safety concern and any other problem. So that is what our society should know. Female neurosurgeons are as good and as perfect and as creative and as productive as the male counterparts. Well, thank you for your attention.
Thank you very much, Professor Kostadim, for this another very interesting presentation. And actually, I think all the presentations today are very interesting. We will have another discussion at the end of this session, maybe for 10 minutes. We still have 3 speakers, and I know that it's late in Asia, in Malaysia, and in Japan. We may be approaching
Sorry,
midnight.
I exceeded maybe a little bit of my time. Looks like.
And I know that is no, that's not a problem. We enjoyed your talk. Thank you very much. And our next speaker, we have another lady from Sub-Saharan Africa, from Tanzania, Dr. Zarina Shabhi. She is affiliated to the Dar es Salaam Hospital, and she is the first graduate She's the first lady graduate from Africa 100 project of Professor Majid Sami. She was trained in Algeria. Zarina, are you here?
Yes, I'm here.
Are you ready to share screen?
Yes.
She's going to speak about post-training experience of a young neurosurgeon, impact of WFNS scholarships.
Thank you very much. I am really honored to be part of this talk. As introduced, I'm Dr. Zarina Shabhi from the Muhimbili Orthopedic Institute in Dar es Salaam, Tanzania. Just a little bit of correction, I'm the first female graduate from the Africa 100 program. Otherwise,
I said that you are the first female graduate because the first male graduate is Isini Ignatius, and he was trained in Egypt. He was trained in Egypt actually through a very long training program approaching 7.5 years. And now he is one of the active young neurosurgeons in Africa, and Egypt is proud that we trained Isini actually. And you are the first lady graduate of Africa 100 project, and you were trained in Algeria.
Yes, sir. Thank you. So first of all, a little bit introduction about Tanzania. Tanzania is a country in East Africa with a population of about 55 million inhabitants and is made up from the mainland and the islands of Zanzibar. So up to 2014, there were only 4 qualified and practicing neurosurgeons, and they were all working at the economic capital of the country here in Dar es Salaam. So there were also numerous international missions that would come from time to time and help in operating of patients. But with time, it suffices to say that through various international collaborations, the WFNS included, Tanzania was able to organize workshops and courses that attracted many international delegates. As seen from the picture here, this was a course organized by the Tanzania Neurosurgeon Society in collaboration with the international community. And here I'm honored to say this was a workshop organized by the WFNS where Professor Yukukatu and her team came to Tanzania. And this was in 2013, and they performed the first aneurysm surgery in the country. And also, I happened to have an opportunity together with my colleagues to attend the inauguration of the Africa 100 program during the 10th anniversary of the Rabat Reference Center, which actually became a stepping stone to my training. So all the time during the residency, I got a lot of opportunities to learn within Algeria and outside the borders of Algeria through Professor Sidisai, the collaboration from members of my department, and through all the other neurosurgeons that I met along my journey. They have taught me a lot from theory and from their personal experiences as well. And I also happened to attend one of the WIN sessions. This happened in Abuja during the CANS meeting in 2018. So a lot of experience was gained as a resident. So after residency, I came back to Tanzania, and there have been a lot of changes concomitantly during the time of my absence. There was an increase in the number of neurosurgeons in the country from 4 to 20. And there are actually 8 residents who are training in different parts of the world. And now even the number of neurosurgical centers have increased from 1 to 5, and there are 2 more in the pipeline. So now there are 2 centers in Dar es Salaam, one at the capital in Dodoma. There is a center in up north in the Lake Victoria region. There is one in the Kilimanjaro region, and one center in Zanzibar. And there is also an established national residency program, and there are various regional residency programs, including the COSEXA program. So milestones achieved as a young resident. I happen to do calls. I work with my colleagues, and we've seen quite a number of patients. These are some of the cases that I have participated in. Trauma, as you can see, assault, pediatric, the myelomeningocele cells, the encephalocele, trauma, spine cases, some tumor cases. The quality of care has improved due to increased number of ICU beds in our center, from 8 to 19 ICU beds and 16 high dependency unit beds. The number and quality of procedures also has increased and improved, including oncology, vascular, spine, pediatric cases. And an angio suite has also been established for endovascular processes. So important to this meeting, also these are the 4 women neurosurgeons in Tanzania. The first 2, we had the first 2 graduates in 2018, and the next 2 graduates in 2020. So challenges as a young neurosurgeon, there is an immense workload because the number of neurosurgeons for the population is still not sufficient. Just in my center alone, in the year 2020, there were more than 41,000 patients seen in the outpatient together with the emergency department. And more than 1,600 patients were operated on emergency and on elective basis. Adaptation and adapting to the new environment, from training, getting more responsibilities. I think I try to explain this with this image here of using multi-plug adapters to get electric flow. So mentorship, I cannot insist more and more on mentorship. The relationship between mentors and mentees is very important to maintain during and after graduation. And we also participate in various projects and collaboration efforts internationally, like the Traumatic Brain Injury Project, the Spine Trauma Project, the ICU Care Projects in collaboration with Weill Cornell University, the North American Spine Society, the Hydrocephalus projects in collaboration with Cure International. We have a global neurosurgery projects together with the WFNS, and we have an annual neurotrauma conference that we've been organizing, and this year it was organized and it was done virtually because of the pandemic. So lessons learned up to this point. I use this as an analog. It takes time, effort, and resilience to acquire skills and experience. Mentorship is a lifetime process during residency and after residency. Learning is a continuous process, and we should always encourage junior colleagues because the road is not easy. So in conclusion, I would like to finish with these slides with some of the members of the Tanzania neurosurgical community. Here is Dr. Shabani, the head of department, and some of the other colleagues and ICU staff. And this photo I took in one of the morning sessions where we have the resident presentations. And these are also some of our colleagues in the normal ward rounds. Thank you very much.
Thank you, Zarina. I think we now move to our next speaker, Abida Shah from India. She is education chairperson of the Women in Neurosurgery section, Asian Congress of Neurological Surgeons. She's going to speak about the relevance of anatomy, dissections, and publications in neurosurgery.
First of all, thank you, Dr. Nasir, for this invitation and for this great venture of your Egyptian Women in Neurosurgery group. A big thank you to Professor Kato for always being a big support to everyone, and she has been a big support and influence in my life as well. So today I'm going to talk about relevance of anatomy, dissection, and publications in neurosurgery. So any surgical procedure is the proverbial tip of an iceberg, the tip resting on a mass of anatomic, physiologic understanding and correlating concepts. Neurosurgery basically is an amalgamation of philosophy, technique, and technology. So this is a painting of a very famous Indian surgeon in the olden times, Dr. Shushruth. And this is an image depicting him of doing anatomical dissections. So you understand how important anatomical dissections were even in those times and how important they remain now. Nowadays, unfortunately, these dissections have been replaced by virtual dissections. Though the quality of these softwares and these programs are very good, they help you dissect layer by layer all the skin and subcutaneous tissue and muscle, but you're missing something. You're missing something from the real anatomical dissection. You're missing the touch of the vessel. You're missing to feel the touch of the tendon, how tough it is, how resilient is your fascia or your cartilage, and you're missing the whole dimension of anatomy when you're not doing anatomical dissection. So dissection is basically like a trekking through the human universe, and all of us neurosurgeons should be completely and absolutely involved in anatomical dissections because it is very relevant for our surgery and it is very relevant for understanding the philosophy of neurosurgery. So as Louis Pasteur said, without laboratories, men of science are soldiers without arms. So anatomical dissections are a core part of the art of neurosurgery, and as is your anatomy, so will be your surgery. So basically, I like the movie Godfather, and just like the idiom, go to the mattresses, is used as in the Godfather very often, a neurosurgeon's motto should be learn and should be to go to the laboratory. So these are various images of cadaveric dissections and microneurosurgical workshops that we have held in our department. So basically, when you do so many dissections, you develop your own technique. You develop, you practice, you become perfect. And your technique becomes your personality. That is the reason an artist cannot teach it, why a pupil cannot learn it, and why an aesthetic critic can understand it. So your technique actually makes you different from the next person. You have to persevere, not until you get it right, but until you are so perfect that you cannot get it wrong. And you're going to get this only by doing rigorous anatomical dissection, by rigorously studying the anatomy and correlating it with surgery. So that is one aspect of our neurosurgery. The next aspect is publications. This word journal is actually a French word, and it means daily. What it means is you enter a daily log of your activities as you proceed in your neurosurgical career. Basically, publications are a very good way of writing your thoughts, of understanding the subject and conveying it to the rest of the world so that they can understand what you're saying, they can appreciate what you're saying, and at a later time amalgamate these concepts into the whole of the subject of neurosurgery. So basically, when you write a scientific publication, it becomes an outcome of involvement and understanding of the whole subject. It becomes clearer in your head. You have the power to change an existing concept. You have the power to change existing thoughts. And by your publication, if your concept is accepted in the general neurosurgical population, then it contributes to the growth of the subject. So that is your importance of anatomy, and that is your importance of publication. Now I will just show you roughly how this has influenced my growth in neurosurgery and how I have progressed in neurosurgery just by understanding anatomy, just by doing rigorous dissections and getting into the surgical part of it. So this is a recent paper that I submitted that is published on the white fibers of the brain. So I started doing white fiber dissection about 12 years back. Okay, that time I used to just do the dissections. I used to understand the anatomy. No one taught me. I just started doing them on my own. It is only after I started doing them and I understood them for 7-8 years that I could understand the entire architecture of the white fibers of the brain. And based on this, I classified the white fibers of the brain according to its direction and depth into these 5 groups. And this makes it very easy for a newcomer in neurosurgery to understand, I hope. So basically, it was the superficial group. This is the yellow circle here, or short association fibers. The middle group of long association fibers that consist of the cingulum, the SLF, the arcuate, the IFOF. Then you have this deep group that is the red circle that will consist of association fibers in relation to the fornix. And you have this green circle here that consists of commissural fibers. This orange circle is the only vertical group of fibers that is made up of projection fibers. And basically, if you see this image, you will see that this vertical group of fibers bisects the middle group of fibers into 2 halves. So the fibers that are medial to this projection system do not cross to the lateral side, and the fibers that are lateral to this system do not cross to the medial side. Now, this understanding I never had when I joined neurosurgery. I did not have it for many years till I was into neurosurgery, but it is only by repeated dissections, by repeated understanding of the anatomy that I have come to this conclusion. So I will just show you a few images of how we proceed with the dissections. So this is the lateral surface of the hemisphere with the pia and all the vessels sitting on the anterior and the middle skull base. And once you remove all the pia and the arachnoid, this is what you'll see, the magnificent cerebral hemisphere. So this is the frontal lobe, the parietal, the occipital and the temporal lobe. There is another lobe here, that is the central lobe, that is only consisting of the pre and the post-central gyri, which are connected by the subcentral gyrus. Then you have the hidden lobe, that is the insula. And then on the middle aspect, you have the limbic lobe. So I'm going to show you quickly just glimpses of all this and some aspects that you will understand why anatomy makes it clearer. So these are short arcuate fibers. Till you remove the gray matter yourself, you will not realize how they run and connect all the neighboring gyri to each other. So if you see, this is an image of a 7 Tesla MRI, where you see how the short connections are connecting all the gyri to each other, and there are innumerable connections connecting the whole hemisphere. So once I've removed all the gray matter, you can see these connections beautifully. This is a connection of the middle frontal gyrus to the pre-central gyrus. Then in the depth here, there is a connection between the pre and the post-central gyrus. And these are how the superior, middle, and frontal gyri are connected to each other by these innumerable short fibers or the superficial fiber system. Once you remove this, you start seeing the middle layer of the fibers, and these are the long association fibers. So this is the superior longitudinal fasciculus, part 2 and 3, as has been traditionally described, but based on my understanding of anatomy, I like to call it the lateral part of the SLF. There is another part that is medial to these projection fibers, and I like to call it the medial SLF. So this is the SLF running from frontal to parietal. This is the arcuate as it runs from the frontal, parietal and temporal region, connecting them. This is a short arcuate fiber system that connects the Broca's area to the arcuate fasciculus. This is just a colored image showing the SLF and the arcuate fasciculus. This is an image with all the gray matter removed, and you can just see all the fibers that are variously connecting all the regions to each other. This is a very solid architecture of the brain, and on this, the gyri I folded to give you the architecture of the cerebral hemisphere. So this was from the lateral aspect. If you see from the middle aspect, I said the most important thing on the middle aspect is the limbic lobe. I will show you again in few pictures later, but this is another important fiber, that is the cingulum. And you never knew that the cingulum connects to the parietal region or to the precuneus by this connection. It connects to the frontal region by this connection that connects to the superior frontal gyrus. Just above this is the middle part of the SLF. You can see some fibers here. Now, how all this anatomical understands helps you during surgery. So now this is the tumor. Okay, this is a tumor. Where is this tumor? It is in the left side. It is in the supplementary motor region. It is in the posterior part of the superior frontal gyrus, which is the classical supplementary motor area. You see how it is related to this pre-central gyrus over here, and it is separated from the post-central by this central sulcus. So anatomically, this is the location. Fiber-wise, if you see this DTI image, you don't even need the DTI. If you know the anatomy, you don't even need the DTI. If you understand where this tumor is, you know that the SLF is displaced laterally. The projection fibers are displaced laterally and posteriorly, as you can see in this DTI image. And if you go ahead and do a resection here, there will be no problem. So here you can see the post-operative image and the post-op flare image. The total tumor has been removed by an NMAS technique, as we have recently described by me and Professor Goel. And you can see this MEP recordings that are showing that it is completely preserved. The motor potentials are completely preserved, and the patient did not have any deficit. Similarly, there is a tumor in the Broca's area. You understand cortical anatomy, that it is in the pars opercularis. So it is eloquent because it is the speech area. This is the functional MRI showing how the area is displaced. Then you understand the DTI. You understand this anatomy. You don't need this, but you should always have this, as it is a good support to you. And believe me, when you're doing tractography images, you have to do them yourself. You cannot rely on a radiologist giving you the images. You go to the MRI or you use your planning station. In this case, we are using a brain lab station, and you draw the fibers yourself. How will you draw the fibers? Only if you know the anatomy, you will know where the fibers are. So here you see the tumor. You see the arcuate fasciculus here, the SLF that is displaced medially, and the projection fibers. So you know that when you enter this tumor and remain here within the confines, you're going to be safe. So this is the post-operative image. So this is a few examples. Now going into the insula. So the insula is covered by these curtains, that is the frontal, the parietal and the temporal opercula. When you open the curtains, you will see the gyri of the insula. As you can see in this image here, the curtains are open and you have the anterior and the posterior gyri that are separated by the central sulcus of the insula, which runs in the same line as the central sulcus of the hemisphere. If you see this image, you can see how the insula is related to the deeper structures of the hemisphere. So this is a recent image. I've done this in the last 6 months during this COVID pandemic, and it enhances the understanding so beautifully. You see this anterior part of the insula that is related to the caudate and the frontal horn, posterior part of the insula related to the atrium. So as we go further, I remove the opercula. These are the gyri of the insula surrounded by the circular sulcus or the limiting sulcus of the insula. Once you remove the gyri, you have this extreme capsule, which is then underneath that you have a thin gray layer that is the claustrum. Once you remove that, you have the external capsule. So this is the ventral part of the external, this is the ventral part of the external capsule. This is the dorsal part of the external capsule. This is the putamen. And just beneath that, you will have the internal capsule. So when you're operating on insular tumors, you realize there are so many layers of safety before you actually reach the internal capsule. So if you understand this, again, the enhanced understanding and operating on insular tumors becomes easier. So this is an image showing the classical spoke and wheel appearance of the insula. This is the external capsule. This is the putamen. And deep below here is the internal capsule. So this was the dorsal part of the external capsule. The external capsule also has a ventral part. This one is consisted of the IFOF and the uncinate fasciculus. The IFOF runs from the frontal part to the temporal part just beneath the arcuate to form a component of the sagittal stratum. And the uncinate runs from the frontal pole to the temporal pole, as you can see in this image. So here, this is the IFOF that is depicted. This is the dorsal part of the external capsule. And now you can see the components of the sagittal stratum. So the sagittal stratum is made up of a layer of fibers that is consisted of the IFOF, fibers of the anterior commissure, optic radiations, and finally the tapetum. These are the major components of the sagittal stratum. And this is the last layer here, that is the optic radiation. So here you can see the IFOF running, just beneath that is the optic radiation. And this fiber here in this region is the uncinate fasciculus. So going further, once you remove everything, the last layer that you have from going laterally will be the internal capsule. So you come all the way laterally and then you have a barrier there, that is the internal capsule, which has the anterior limb, the genu, the posterior limb, the retrolenticular portion and the sublenticular portion of the internal capsule, which is the Mayer's loop of the optic radiation. So now again, understanding the anatomy of the Mayer's loop led to another realization. If you see this area here, so this Mayer's loop is in the roof and the lateral part of the temporal horn. So if you see this area here, underneath that, in the region of the temporal horn, there are no fibers. There are no optic radiation fibers. So it is safe to enter in this region. I will show you the images later. So these are just some peri-insular tumors. You can see in the region of the superior temporal gyrus, perisylvian. And you can see, if you understand the anatomy of the fibers, you can safely go in and perform a beautiful resection. Similarly, for tumors in the insula, you understand the anatomy of the insula, of the IFOF, of the arcuate, of how the internal capsule is displaced laterally. And you can go in and you can see this wonderful radical resection that we have performed. This is another small technique that I developed when I was a junior, using indocyanine green as an adjunct for resection of insular gliomas, which helped me to differentiate between the vessels while operating. I don't want to show the video for the lack of time, but you can see this vessel here, which was involved by the tumor. I was not sure if this was a tumorous vessel or going further on. So I used ICG, identified it, and separated it completely from the tumor and preserved it, as you can see here. And this is the tumor that was completely resected, as you can see in the post-operative image. So as I was saying, these fibers of the IFOF. So when you see how they cover the temporal horn, so you see these fibers are running here, IFOF, and beneath that the optic radiation. So this area here, that is just overlying the head of the hippocampus, does not have any fibers. So you don't know this if you don't know the anatomy. So you enter from this region safely, and this approach for using this was described and is used in our department for doing epilepsy surgery by Professor Goel. We use the middle temporal gyrus to enter this region. As you can see here, we enter from this region, which is devoid of any fibers, and then do a complete resection of this area an en block way, performing a very beautiful resection. So this is just a dissection image to show how much we remove. This is the whole area that is being completely removed by epilepsy during our epilepsy surgery. So you can see in this region that there is no white fiber that will come in the way. This gray structure that you see here is the amygdala. So again, an image showing that this part of the temporal horn is safe to enter. There are no fibers here, and you enter and perform the resection. So again, this is a medial temporal tumor that I've operated using the same approach, and you can see the beautiful resection that has been performed. Another medial temporal tumor that has parahippocampal tumor that we have operated. You can see how the fibers are displaced by the DTI, safe to enter from below and remove the entire tumor. So this understanding comes when you're doing the anatomy. So another approach that we recently described. So you see this basal surface of the frontal lobe. This is the H-shaped cruciform sulcus of Rolando. This is the medial, anterior, posterior, and lateral orbital gyri. So this approach we described it earlier to approach deep-seated lesions in the region of the caudate nucleus or for lesions around the frontal horn. This was described by us earlier in 2009. And now we have modified this approach. I have identified two trajectories which are safe to approach the caudate head without causing any problem. And you can see in this dissection image, this is the medial trajectory and the lateral trajectory. The entry point of this one is through the middle orbital gyrus, and the entry point of this one is through the lateral orbital gyrus. And you enter safe from this region. There are no fibers in the way. This is an image of the basal surface of the brain. This is the anterior commissure. This is the uncinate fasciculus. And if you see in the depth, this is an upturned image. So this is the frontal brain, temporal brain. This is the frontal horn. This is the region of the caudate. So either you can enter from here or you can enter from here. And there are no fibers that are going to be damaged. Just maybe a small portion of the forceps minor that may come in the way, but that does not cause any consequence. So again, this is the tumor of the caudate head that we've operated using a lateral orbital trajectory. You can see the fibers that are displaced and separated by the tumor, safe to enter from this region. And lastly, the limbic system. As I told you, this is one of my favorite because this is one of the first things that I did when I started doing my fiber dissection. This is the cingulate gyrus, which continues in the parahippocampal gyrus, as you can see here. And the parahippocampal gyrus also has a continuation as the lingual gyrus in the occipital lobe. So once you start dissecting from medially in the region of the thalamus, you start seeing the mammillothalamic tract and the mammillary body. This is the dissection of the superior part of the limbic system, where you can see the whole cingulum beginning in this region, the subcallosal region, going up and coming back down into the temporal region here. And this is the connection of the cingulum to the frontal, superior frontal gyrus, and this is the connection to the precuneus. So once I've dissected the mammillothalamic tract here and the anterior nucleus of thalamus, to dissect further, I cut the corpus callosum and then lifted the caudate head from this region, and you start seeing the anterior thalamic radiations as they connect the thalamus to the cingulum in this region. So this is the whole Pape circuit. This is the uncus. This is the region of the hippocampus, and the fimbria, which become the fornix, the columns of the fornix, the mammillary body, mammillothalamic tract, anterior nucleus of thalamus, anterior thalamic radiations, cingulum, and then back again to end in the entorhinal area and the parahippocampal area. And this is the whole Pape circuit that we dissected outside. And also this is another component of the limbic system, the olfactory tract and the medial and lateral olfactory striae. So this was one of my first papers on fiber dissection that I had published in 2009. So this again, how this knowledge helps you. You understand during surgery of limbic and paralimbic tumors. And this is the parahippocampal tumor that has been radically resected using this middle temporal gyrus approach from inferiorly. There are no fibers in the way except the inferior longitudinal fasciculus. This is another tumor. And lastly, the corpus callosum. This is again recent work that I've done in the last 6 months. Beautifully dissected the anatomy of the corpus callosum. As you can see here, I'm dividing into 4 parts. So you have the dorsal callosal radiation, the ventral callosal radiation, the posterior and the anterior. This is the forceps minor, that is the anterior, forceps major, that is the posterior. And you can see all the radiations in different colored images and how they're related to the IFOF. Importance for surgery is you can perform a callosotomy in this region or in this region where there are no motor fibers here. And to perform a disconnection for epilepsy surgery, you have to go all the way from the front to the back to this region and disconnect the motor fibers in this region. So this is another corpus callosal tumor, which based on the understanding of the anatomy, This is the fiber displacement that you can see, and we've performed a radical resection of the tumor. So this is just a small glimpse of how anatomy has influenced my surgery. And this is a nice saying from Michelangelo, that if people knew how hard I worked to get my mastery, it wouldn't seem so wonderful at all. And you can see this in this beautiful masterpiece of the Taj Mahal, that is a wonder of the world, and how much mastery and how much work had gone into making this. And thank you very much for your attention.
Thank you, Abida, for this great presentation as usual. And actually you are making neuroanatomy, which is already one of the most difficult subspecialties. You are making it very simplified and very illustrative. Actually, after I listened to your talk last Friday in your webinar, I sent email to Atul Goel, he's my friend, and congratulated him about this excellent presentation. Thank you very much. We still have one speaker from Egypt, Dr. Mariam Ghanem. She's going to speak about stereotactic biopsy for brain lesions, not amenable for microsurgery. Mariam, are you here?
Dr. Nasser, yes, I'm here.
Okay.
I'm sharing screen. Thank you, Dr. Nasser, and have a good day, everyone. I'll talk about a stereotactic biopsy and brain lesions, not amenable for microsurgery.
Can you share your screen, please?
Already, I share my screen.
We can't see.
Share it again, Amar. Share it again.
Okay.
It's okay now.
Are you
It's
seeing the
okay now.
screen? Yes.
Yes, yes, okay.
I'll talk about a stereotactic biopsy and brain lesions, not amenable for microsurgery.
Make it a full screen. Yeah. Okay. Now.
Full screen, okay.
Yes.
In fact, we are facing sometimes some cases that ask us in taking the appropriate decision in how to deal with them. Either we are doubtful about their radiological diagnosis, or those patients can benefit from other modalities of treatment rather than this. I include multiple inflammatory lesions, multiple infections and radiological diagnosis, or if the patient has good general condition, cannot tolerate general surgery, or if the patient refused craniotomy and he can benefit from other modality rather than open surgery. I excluded suspected lesions, very large brain lesions,
Mariam,
suspect uncorrectable coagulation disorders. Okay, Dr. أنا أسمع حضرتك.
Okay, okay, go on.
Okay.
Yes, yes.
Gas to coma score less than 8. All my patients in this study was on triple assessment, clinical evaluation, imaging evaluation, and histological sample diagnosis. This study was done years on 50 patients. The frame system and Nasser Institute use the system, and we use navigation, frameless system, and Sahel teaching hostel. I'd like to share some technical notes to achieve high accuracy in my work. We concentrate and keep my attention in 3 main stages: pre-operative and operative and intraoperative. Pre-operative stage, we keep our concentration about accurate site of frame application and high quality of stereotactic CT scan. What I mean by accurate site of frame application, I mean the location of the lesion in relation with this. What I mean exactly. This is the base ring applied here, and this is the epicrucial. This is we apply the frame to allow the lesion to be detected in the region of the epicrucial and to be away from, to some extent, from the base ring, to be away from the artifact produced by the CT scan. This an example for a female patient who have a frontal temporal lesion. We apply the frame in this side and in the upright direction to allow the lesion to be in this area on the epicrucial. On the other hand, not all patients we can do this this direction of the frame. We can use the opposite direction, like this patient. This patient had a temporal lobe enhanced lesion, and we can use the direction in the opposite manner. I mean feet to head direction, and the Murano stem system allow us to do this, to opposite the direction of the frame. During the frame application, we done the frame application in the operating room. We used local anesthesia at the site of the pin and the insert pin diagonally. I mean right frontal at the same time with the left posterior and so on. And in the outer table of the skull to avoid fracture of the skull bone. To achieve a high quality of a stereotactic CT scan, we always use with CT with contrast. We do it at the day of surgery and be sure that all fiducials can see the arrow. We should assure that all fiducials are clearly detected by the software of the system. How to choose the target? For solid lesion, we choose the target from the most enhanced part of the lesion, as we can see here in this picture. But for cystic lesion, we try to choose the target from the solid part, as we can see here in this picture. This is a stereotactic CT scan image. This is the site of the target. When we deal with the navigation system, we try to achieve navigation accuracy by CT scan quality, high quality. We use a CT with contrast one day before surgery, and we instruct the radiologist to take a thin film, 1.5 to 2 centimeters, zero spacing, no overlap, no gum detail, showing all the nodes. Here is the photo showing the patient in the operating room. The patient head is fixed by the Mayfield with the operating table, and this one of the difference between the frame and the frameless system. Then the registry, the photos taken one day before surgery are transferred to the software of the navigation system. Here, patient on general anesthesia, not on local. Here is the fiducial, as you can see here, not attached to the skin, but is attached to the Mayfield. Some operators, the fiducials are put on the skin, but here we deal on the fiducial attached to the Mayfield. Here is the camera lens, detect the fiducials, and we use a trace probe to treating the skin, including all the nose and all the scalp surface, to be sure that all data transferred to the software. We choose the target point by the same rules from the most enhanced part of the lesion. While doing the biopsy procedure, we keep our concentration and some technical notes. We use local anesthesia with intravenous sedation for adult patients in order to make the patient stable, no movement, to ensure accuracy of the procedure. We can see here the base ring is attached to the Mayfield, the arc is attached to the base ring, and the needle biopsy is attached to the arc. But on the navigation system, one case in my study was a child, we use a general anesthesia. She was not cooperative, so we use general anesthesia to ensure stability of the patient during the procedure. Frameless navigation system, we use general anesthesia, no frame. The biopsy needle is attached to the Mayfield clamp. And during the procedure, we double check the coordinate. This is the phantom arc. Put the coordinate XYZ on the phantom arc. This point represents the target point of our patient. And this is the tip of the needle. When software of the apparatus is adjusted to take a biopsy, the tip of the needle should be below the target by about 2 millimeters. I mean, not the tip on tip, but below it by 2 millimeters to take a biopsy, a good, accurate biopsy taking. The length of the needle is fixed almost in frame system for about 16 to 70 centimeters, but in frame system, we adjust the length of the needle according to the distance, imaginary distance calculated by the software.
Please, Mariam, raise your voice.
Okay.
Some participants and audience complain for the voice.
Okay. We try to choose entry point. We try to choose entry point fashioned according to each lesion. Here are some examples. This patient has a temporal, superior temporal enhanced lesion, superior temporal entry point. And this is another example, parietal entry point and superior parietal entry point, frontal biconal entry point. Skull interest was done using twisted drill or pair hole, but in our study, twisted drill was better than pair hole because there was no CS technique to avoid brain shift. But when we use pair hole, when we do a pair hole, we try to waxing the hole to avoid CSF leak and avoid brain shift. Biopsy needle, when introduced, we introduced it first through, then open it. We use a safe trajectory, avoid any vascular structure, avoid passing through a sulcus. We apply gentle suction force rotation. We use a syringe, 3 milliliter, and multiple sections of biopsies were taken along the 4 direction, and we take about 4 to 6 bites at serial depths. The biopsy revealed or inspected for amount, number of biopsies taken to be a sufficient amount to do a histological examination, and for the color. And normal color of brain is different than the lesions. So we sure that the color and the amount is sufficient to do a histological diagnosis. Try to avoid brain shift. We try to avoid brain shift by continuous dribbling of saline, drop by drop, to avoid entry, and we try to waxing the pair hole to avoid CSF. We do CT post-operative for few cases to verify targeting. Here is the example. This is the target site, and this is the post-operative site of the biopsy. And we can see here no bleeding, post-operative, no brain edema. This is another example. This is the target, and post-operative, this is the site of the biopsy. We can see here a brain edema, but if we compare it with pre-operative, nearly equal. So there is no complication in this case. Do CT post-operative for one case, develop intraoperative minimal bleeding. Rest of our cases don't require CT. I'll present some of my interesting cases. In this male patient, he presented with headache and post-auricular enlarged lymph node, firm to hard about 1.5 centimeter from examination. This patient, when we saw MRI, we suspect solitary metastasis from the location and from the examination. We advise patient to do a metastatic workup. When CT abdomen contrast was done, it revealed a right suprarenal mass with parahepatic lymph adenobasis, and patient advised to complete radiological examination. MRS was done and revealed high-grade malignant neoplasm. The patient decided to complete his management with the oncologist when the oncologist advised him to take a biopsy from the primary lesion, but we advised him to do an open surgery. He refused. We advised him at least to do a stereotactic biopsy. When the biopsy was done, it revealed astrocytoma grade 3. This is an example showing us how can stereotactic biopsy adding an advantage superior to the traditional imaging and alternate the line of management definitely in this patient. This is another example, male patient, 65 years old, diabetic hypertensive with history of pulmonary embolism. He presented with recurrent attacks of fits and left side weakness. When this patient do MRI, we show a lesion right temporoparietal extended to the brainstem with enhancement. But the report of MRI reports that this is a vascular stroke. We advise the patient to complete his radiological examination. MRI spectroscopy was done and MRA was done, and also reveal a cerebrovascular stroke rather than being neoplasm. But in fact, we are doubtful about the radiology, so we decide to take a biopsy. Biopsy revealed remestrostatic rich astrocytoma grade 2. This patient will complete open surgery, and the open surgery confirm the histological diagnosis of the stereotactic biopsy. Here we can see another advantage of the stereotactic biopsy, adding superior to that traditional imaging we can deal, and how the patient's line of management completely differ from a vascular stroke to an astrocytoma compressing to the brainstem. Here is a male patient, 61 years old, diabetic, complaining of headache and vomiting. He gave a history, past history for chest hospital admission. When this patient, when the CT scan of this patient was done, it revealed different multiple enhanced lesion. But if we see this picture, we can see different phases. This is a ring enhanced lesion here, diffuse enhancement, diffuse enhancement. This picture matching with infection rather than to be metastatic. Advise the patient to do a biopsy already when the biopsy was done, revealed myogenic infection. This female patient have 68 years old, right side weakness, grade 1, and headache, and have a lesion on MRI at the motor area. This female patient, we advise him to do a biopsy that already have a grade 1 weakness. When she submitted to an open surgery, it may develop a new deficits, or the deficit may increase. The biopsy revealed glioblastoma multiform, and she advised to complete radiotherapy. This male patient presented with headache and left side weakness. The MRI of this patient showing a vivid enhanced lesion. We suspect from the radiological finding that is lymphoma. And this patient can benefit from radiotherapy rather than to do open surgery. We know this from the radiological examination, but we do the stereotactic biopsy to confirm our diagnosis. The biopsy revealed non-Hodgkin lymphoma, so we can see here how a stereotactic biopsy confirmed diagnosis and put the person in the correct manner of treatment by a minimal invasive method and safe. So our results, we achieved a diagnostic yield, 94%. Most of them was glial neoplasm. The second was non-glial neoplasm, and the least was non-neoplastic infection and infarction compared to other studies. We get solid confirmation in 94% of cases. Solid confirmation, I mean, the report revealed that glioblastoma or astrocytoma grade 2 or Hodgkin lymphoma. Suspicious diagnosis was obtained in 4% of cases, like what happened in this case. It revealed malignant mucus tumor. We consider it as suspicious. Negative diagnosis, and when we correlate the result of metastatic 4% and not matched in 28.5% of cases. In my study, there are 20 patients on spectroscopy. Them was not conclusive. It gives possibility of a reverse plastic. When we do a stereotactic of the was astrocytoma grade 3 and with astrocytoma grade 2. So we achieved a solid agreement between the two methods, histological examination of a stereotactic biopsy comparing to the MR spectroscopy in 65% of cases, and stereotactical and MR spectroscopy was not conclusive in 10% of cases, and partial agreement was present between them in 25% of cases. No agreement was found in one case, 5% of cases. We're facing complication. Minimal intraoperative bleeding was known in one case and failed biopsy in two cases. One of them was inadequate biopsy and the other was negative biopsy. This patient was a diabetic with myocardial infarction, history of previous 2 strokes on platelet antiplatelet medication till the day of a stereotactic biopsy. When we take the biopsy, we develop a minimal bleeding during the procedure. What we do in this case, continue dribbling saline, drop by drop, last about 2 hours to keep the field clear. And patient post-operative was quite no neurological deficit developed. 2 patients in my study was failed biopsy. One of them was a female, had a left-frontal lesion. This patient had a renal impairment, liver impairment, so we cannot use an enhancement during the scanning. We take the biopsy from the junction between the hyperdense and the hypodense area, and it was a negative biopsy. It revealed totally necrotic devitalized tissue. We consider it a negative biopsy. The other patient was 63 years old male, had the right parietal cervical enhanced lesion. The biopsy was taken from the hypodense periphery. The biopsy revealed inadequate biopsy. We redo the biopsy in this patient, and it revealed glioblastoma not small. Take a home message in my study, doubt for radiological diagnosis. We should do a stereotactic biopsy to confirm the diagnosis. Short hospital stay, safe maneuver, minimal invasive, diagnostic yield of frame system compared to a frameless system nearly equal. Frameless system is more comfortable than for the patient can frame out. Thank you.
Thank you, Mariam. I don't think we have any time for any more comments or questions because time is approaching to be midnight in Japan and in Asia and in Malaysia. And Bida sent me a message as she has to leave. At the end of this session, I would like to ask Professor Yukukatu if she would like to say something before I close the session.
Thank you very much for the almost 3 hours. A very good discussion among the Egyptian and also Tanzanian. And I think in the future, this is a real first collaboration, the webinar. But we expect the second and third. Maybe you can invite not only the Egypt, but also the whole Africa. I think we have more the mutual collaboration and also the communication. It was very fruitful, the webinar. Thank you very much for organizing this wonderful one. Thank you.
Thank you, Professor Katu. And actually, we will be honored to arrange another webinar with you soon. I'm going to communicate and to arrange about this. It's going to be honored and it's going to be covering all the African continent. Maybe you have more speakers from Africa. Ladies and gentlemen, today is going to be remembered. That's the inauguration of the Egyptian women in neurosurgery by the support of Professor Yukukatu. At the end of this session, I would like to thank Professor Yukukatu for supporting our initiative. I'd like to thank all our distinguished speakers. I'd like to thank all our attendees. Remind everybody that the certificates approved by the World Federation of Neurosurgical Societies will be available to be printed electronically just a few days after the webinar is finished. Another important announcement that next day at the same time from 2 to 4, webinar number 33 is another WFNS event about pediatric neurosurgery, which is going to be organized with the Pediatric Neurosurgery Committee of the World Federation of Neurosurgery, Professor Nelsie Zenon. Thanks to all of you. May I not forget to thank IT persons, Ahmad Adil and Adil Idris for supporting this webinar technically. One more time, thank you very much, Professor Yukukatu. We are all appreciating as African and as Egyptian neurosurgeons, you are supporting everybody in Egypt and Africa all the time. Thank you very much and see you soon in another occasion. Thank you very much.
Thank you, Professor Katu. Thank you. Thank you for the audience, for all the speakers. Thank you very much.
you so much, doctor. Thank you.
Dr. Omar.